All right. Welcome everybody to Scholars Dental Situational Judgment course. I'm Dr. Hafez. And we have our head instructor for the Situational Judgment, Dr. Saif.
Good morning, everyone.
What I'm going to... Can Natasha just... I'm sorry. Okay, so what I'm going to do today, just show you how the course will work, and also show you the platform and introduce you to that. It won't be too long, and then you guys could get on with the first day lecture of the Situational Judgment course. All right? So let me show you guys what our plan is. And first, I'm just going to share my screen to show you the schedule and the platform. So once you register for the Situational Judgment...
Sorry to interrupt you, Dr. Hafez. Guys, just a heads up, if you cannot hear us, you just have to head to the bottom left corner of the screen, select the microphone, and you can change your speaker to the speaker you are using, just for the ones who are having difficulty hearing us.
Yeah.
And at the same time, you can select the source microphone as well.
Let's wait maybe a few more minutes. How about that too, just in case? Let's get everybody sorted out. Is anyone here planning to take the Situational Judgment soon? You could just type in the chat, yep, and maybe like a month that you're planning to take it.
Actually, as well, from the ones who's attending, if you have finished the ACJ, then you can just mention that in the chat as well. No, the course here is for situational judgment. So it's basically the third part of the NDECC process. It comes after the ACJ. So you finish AFK, ACJ, and then you get to the NDECC, and the NDECC is going to have the situational judgment and the skills part. So this is the situational judgment part here, which is you're only eligible for once you finish the ACJ. All right, I believe we're good, Dr. Hafez. Yeah. Get correct.
Let's give it another just 2 minutes. Just some people, we have more people who want to jump in, so they don't miss out on the.
Okay.
Yeah, we'll just learn more about you guys. Is there no one typed anything? Anyone planning to take the SJ? Come on.
Also, if you again to Dr. Hafez's question, if you have finished the ACJ or not. The reason being is the situational judgment is an interactive course. So if you are planning to get the situational judgment, if you're planning to sign up with the course, or if you're planning to proceed elsewhere and to make the benefit out of this session, it is for your best interest to just go live on your camera, because by the end of the day, the more interactive it gets, the more benefit you will make out of it. Okay. Yeah, majority of people now are aiming to get the NDECC Part A or Part B in July. Yeah, because the next registration is going to be in May.
When you say the next registration in May, isn't it open that like every week there's a date, or is it the opening date?
It is when they open registration, so they open it for the next 2 months, which is the next 10 sessions.
Oh, so they open it one day for the next few months. Is that correct?
Now one day, they open it for like a good week, actually, a good week and a half. But then seats tend to be filled within the first hour. However, there is a good enhancement nowadays with the system where they're letting people register. They're providing, I wouldn't say more seats. Seats are capped. However, they're prioritizing the exams for the people who failed one competency, for example. Then they're letting them sign up for ACS only or situational judgment only. And they give the priority to the ones who've never done it.
Like if there's, let's say, 4 weeks of exams, it's not like each week has its own registration date. It's like the whole 4 weeks have one registration opening date.
You select the dates within.
So it's like a bulk. Yeah.
Yep.
Okay. So all these things are, important things to learn if you're new to this, because you want to know when you have to be ready to register, when the seats will be booked, right? So they could ask you that as well.
Yeah, exactly.
So we know one planning in July. Anyone else?
Are you guys also, if you can write, please, in the chat, if you have finished the ACJ or not. Also, if you are in Canada or outside of Canada as well. Actually, even for ACJ, they just opened up actually a month ago, more seats in the USA.
Yeah.
And they might be accommodating more people here. So that's the initiative that we're seeing from the NDEB nowadays, which is a pretty good step.
Yeah, many of our students got more seats. And the results came out last week about AFK.
Oh
Did you
yeah,
hear about that?
I heard like
Yeah.
it's a good percentage of the people who passed as well.
I didn't look at general, but we did well. Yeah. So our students were pretty good. Like the adjusted passing rate for us was around 97% this time, which is
Okay.
like higher. That was pretty good. So we're still collecting, but we do evaluation tests, and everybody that got over a certain mark and those tests before the exam passed, like 97 passed. That's pretty good.
That's pretty good, actually. Yeah.
I finished ACJ and will start situational judgment course around August. All right. Thank you for sharing.
Thank you, guys.
Okay, planning to take ACJ in May. That
so part of the
means
attendance. Yeah. So that means
good
also
to be early. Yeah. You're planning ahead. That's a good idea. You're learning about all the things. Welcome. Yeah. All right. So I'll get started, and then maybe we could the rest that will join. There might be joining late. They could see it in a recording later. Let me show you guys what the plan is for anyone that's interested in this situational judgment. So it's going to be a 2-month course, 8 weeks, 1 session every week on Saturdays, starting 10 a.m. until around 2, maybe 2 plus, like depends on the day. And it's a mix of theory, but mostly there's going to be a lot of practice scenarios as well. Now, in addition to that, you will receive access to our platform. Okay, so you can see here, once you're a student, you'll have access to our platform here, and you have your Zoom session link and your schedule. Okay, so your sessions will be Dr. Safe, will be Saturday at 10 a.m. and they will be recorded as well. And also here's your schedule. We'll show you like every time. But the best part is you have you also have access to all the lectures from before. So here's all the 8 lectures from before that we did, along with the slides uploaded. You can see. So you go through them here on our platform and the recordings from before. Okay, so let me just
things we're going to ask for.
Have you been followed by your physician? Do you take, have you been ever hospitalized about that condition?
Just to make sure, can you guys hear the videos?
I can on my end, so I believe it's working.
Okay, good.
Do you have any signs and symptoms? And if you do, when was the last time that you experienced the
All right, so you can see in our platform.
Thank you for your patience so far. I have.
We just kind of start with
thank you for your patience.
Hi, Saif. Good morning. Thank you for
just to kind of give you an overview of how the course is.
We should always start with thank you for your patience so far, because the person started the conversation already. We should pay attention to these things.
Thank you for your patience. I have different questions for you regarding your medical history. Is there anything that I need to be aware of?
No, just the first question. Is it really necessary that you need to know about my medical condition?
So just to let you guys know, Dr. Safe here is playing a patient role. Okay, so Dr. Safe is being the patient, and he's really good at taking different patient personalities, I noticed. So every time I see him, sometimes, you know, he's
Yeah,
playing a
that's the
drug
challenge,
addict.
actually.
Sometimes he's
True.
playing. So he has some natural talent to being different people. Okay. Over here, he seems like maybe a little bit, you know, a patient that's just wants to get things done and stop
Yeah.
asking questions kind of person. But you could, he's not just saying that as an instructor, he's being a patient, and Dolores is being the doctor. Okay?
Doctor. Which is might
I would
actually like
to know-
reflect how you are in the exam with the actor as well, because sometimes you might get like a tough actor or like a nice actor or a well-spoken actor who
Exactly.
keeps talking and wasting your time. So that's one of the scenarios there.
If there's anything that can interrupt our treatment later, or if you have any medical conditions that I would like to be aware of.
Oh, okay, sure.
So should I be aware of anything? Do you have any
no.
health problems? Do you take any medications?
No, not really. Not that I can think of.
When was your last medical checkup?
I actually get checked every 6 months.
Okay, that's good. Thank you. Do you, regarding your tooth, do you have any feelings on it? Was any dental work done previously on that?
He's gonna forward
We
a bit.
recommend 2 times a day. But do you floss?
Okay. I do floss, yes.
You do floss. Okay, that's good. The checkup.
Yeah, I'm trying to provide you with the best answers I have. I know it's important for you to.
So you could see here, this is just the 3rd lecture. So we get into the practice pretty early. And it continues. Where was the one I wanted to? I think it was 8. You know, we keep going until the end. So you could see maybe the improvements, the changes.
And I'm here to extract my tooth to 5 because it is not restorable. And at the same time, I have TB. So manage and treat me.
Okay. Hi, Safe. Thank you for visiting us today. How are you doing?
I'm doing well. Thank you very much. It's been a while since I was last at dental clinic, and finally I'm here, but unfortunately I'm not here to clean my.
So here, Dr. Safe is not the same patient. He's a different patient for an extraction and has tuberculosis, right? So we're playing that scenario here.
I'm here to extract that tooth.
Okay, sounds good. My name is NDEB number whatever. So I'll be here helping you today. And are you in pain right now?
I am in pain, actually. Yes, I cannot bite on the tooth.
Okay. Before we proceed, I saw on your medical history that you have tuberculosis. Is that correct?
Oh yeah, that's correct. Yeah, true.
When were you diagnosed?
I was diagnosed actually 3 weeks ago, something like that.
Do you have any symptoms?
I cough every now and then, to be honest.
Cough every now and then. Okay. So
yeah.
Okay. Did you report your illness to the public health?
Oh yeah, there was a form online. I filled it and then I just sent it out.
You send it out. Okay. So just to be sure that you did everything correctly, it's my ethical and legal duty to report it as well. So I'll be proceeding with that to prevent any spread in the community.
We did not even start the treatment and you want to report me now?
Yeah, because this is a very dangerous disease which can affect a lot of people, and we need to be safe, and we need to, it's a standard of care.
What do you mean is it a dangerous disease? I'm going to die?
Well, are you under any treatment right now?
So you could see it's a really good way that Dr. Safe will put you under the spot, you know, and put you under that like scenario where you're like, oh man, what did I say? Did I say something wrong? And I think the actors will.
That's just how it is. Yeah.
Exactly.
It's how you manage your patient.
Okay, and this platform will work on your, on your phone, your tablet, your computer. So not only you're getting the 8 lectures, but you also could watch the previous 8 lectures, which is an amazing value. And you're getting the practice part from lecture 3.
Literally, also the scenarios.
Lecture 3.
Yeah. Actually, from the second lecture we actually start, because there's even, to be totally honest, there's still even like cases we start from the first lecture, which is what's going to happen today. But even those scenarios, the recorded ones or pre-recorded ones, they're going to change. So the variety of having new cases, new scenarios versus the old one, versus seeing other people how they react is also like a different experience.
Exactly. So we're not saying the student is necessarily doing the ideal answer. It's just good to watch the scenario, how it unfolds. You could learn from it and see Dr. Safe's feedback. Also, you'll sometimes have a timer so that you see how long it'll run, because you want to try to keep the discussion going as long as the question, I think, right? The timer,
Yeah.
10 minutes.
10 minutes.
Yeah. So just showing you guys how the course will work. Do you guys have any questions for me before you start? And then you guys can start the day 1 lecture.
Thank you very much, Dr. Hafez. That was actually a nice recap of what happened the previous course. It was fun. But yeah, as you guys can see, like it's an interactive course. So if you are aiming to give the NDEC anytime, if it's this year, if it's next year, if it's next month, like we do have people who are having the exam literally next month and they just started. And we have other people who are planning to have their exam in August, July area, like where most of the people are planning for. Others did not even start. They're still in the ACJ. So the course is not about, and the way you used to take AFK and ACJ, where you used to memorize things and do things. You have to present yourself. So you have to be what you saw in the video. You have to be that patient. You have to be that dentist. And it depends within that 10 minutes what you're going to give and what you're going to ask and what treatment options are you going to give. You have 10 minutes and you have to present things. So you can't memorize things. You have to be that person. So the only way to do it is literally to be as interactive as you can get. So I would ask multiple people of you, whoever can, to open up their cameras and microphones to make the benefit out of the lecture. And then we get to start. Because situational judgment is not theory. It's not just theory where you're going to look at things and go over them. It's how you're going to present the information, the way, how to control a mad patient, how to control a very nice patient who talks nonstop, who would waste your 10 minutes. So the more interactions you get, the more interactive you get, the more benefit you will make. And by the end of the day, you will have that muscle that you're going to be growing in the next 2 months, which is the 8-session course that we're going to be having every Saturday. You're going to build that muscle. And then after that, you can expand your options by having more practice to yourself. But that's literally how we tackle the situational judgment exam. So it is interactive. You will be in a shock once you arrive to the NDEB building and you get to the exam room, for example, because you're going to be actually faced with actors. And those actors, what they're going to be doing, they're going to be throwing obstacles. So what are the obstacles? They can be, again, mad patient, laughing patient who would make you laugh, a patient who dressed up in a funny way who would want you to like laugh, for example, a patient who would not let you talk, a patient who's very scared, a patient, for example, who is very knowledgeable, who knows what amalgam is and he knows what mercury is, and whatever you tell them, they come back and tell you, yeah, but we know about it. We have like an RCDSO article saying this, and we have a CDA article. So now you're faced with a patient who's actually invested in knowledge. So each of those patients are going to have to build a way of how to answer them back and how to dodge them in order to make those 10 minutes with the best information delivered. So I would encourage you guys to, a couple of you, if you would please open up your cameras so we get to start.
All right. And
seems like Rami is going to be the lucky one. Good morning, Rami. How are you?
When you said
I
throwing
cannot hear you.
obstacles, I thought you said throwing popsicles, and I was like, hey.
I wish.
That's not too bad. All right. I'm gonna hide. There you go.
All righty. Thank you very much, Dr. Hafez.
Good.
And I believe you guys can see my screen. Rami, can you see my screen, right? All righty. Sounds good. Can you hear me? Because I cannot hear you. Alrighty. Everything with the situational judgment revolves around interaction. So I would be focusing most of the time on your interaction. So that's why I ask everybody to jump. And just like I'm going to speak to Dr. Rami. So Dr. Rami, just to start an interaction, can you please tell me a little bit about your background? When did you get to the situational judgment? And if you have finished your ACJ?
Hi, Dr. Steve. How are you?
Good, good, good. How are you?
I'm good. Thank you for the lecture today. I finished my ACJ May 2022, and
Okay.
then I took a course online for the situational judgment. That was also last year, and I was planning to do the NDECC in January or February.
Okay.
But then I decided to like postpone it and be more ready. So
Okay.
after I saw the passing rate, it was so low. So now I'm planning to do it in July, inshallah.
Okay, that's pretty good plan actually. And thank you. By the way, guys, even that little interaction that I just had with Dr. Rami matters. And we're going to see why very soon. So we'll start with the lecture, and basically we're going to be going through the things that I just spoke about, and you're going to see the benefit of it. Okay. So the agenda of what we're going to be doing, we're going to be going through the references. So the NDEB did already mention the references that we're going to be using, which is their own RCDSO references, and we're going to go through them now. How to study, we're going to go through it as well, how you can approach the exam. Too many questions from all the candidates. They've been through us, and even before we start the course, everybody's like, Dr. Saif, can you please give us more papers to study or more theory to study? But again, the exam is not about the theory. It's not solely about the theory. The theory is only 40 to 30% of it. The majority of it, and this has been proven even from the people who don't have much theory database, is the interaction. For the people who can interact and have a message delivered and have a good communication. We call it good communication in real life. However, in the business market, they call it effective communication. Effective communication means you're delivering a message that is actually heard. So you have a clear message that you're saying it properly and it has the correct information and the patient can understand. So that's what it is. That's what situational judgment is. So it's 40% theory, 60% is how you deliver that message. And we're going to be going through a lot of scenarios, which what might happen through the course and what you might be facing in the exam. The references, we're going to be using the NDEB references, the ACFD, which is the top and most important part of the exam, which is what the NDEB is using. So it is a framework. So it's a part of framework that was that came up by the Association of Canadian Faculties of Dentistry. And what it says is basically a criteria that lists how a starting dentist should be looked like. So if you're a starting dentist from University of UFT, from the University of Manitoba, from the NDEB, any dentist graduated in Canada, the NDEB, since they're the one who's doing the last OSCE exam, that's the last exam you do before you get licensed, the NDEB focused on getting all dentists to comprehend and act by their protocol. And their protocol is basically called the ACFD, which is the Association of Canadian Faculties of Dentistry framework. So that framework is what you're going to be tested on in the exam. Other references are going to be throughout the RCDSO, CDA, the ODA, UBC, and the ADA. So it's mostly all universities. And that's the part that I like about the change from the ACS to the NDECC exam, the previous ACS versus now, is the new change in the framework. Because now they are getting you ready to actually be in the market after you finish the OSCE exam. Before you finish the OSCE exam, and when people used to do the ACS exam, they used to go to the market, and now they can barely interact with the patient. So they face that difficulty after when they get to the market, and it takes them a while to get used to it. However, now you are almost like a university graduate. You're just going through a different route, not the university, but through the NDEB. And that was guaranteed by the situational judgment exam addition to the NDECC exam, instead of just doing the ACS, the 12 projects. And as any other topic, wherever we go, copyright infringement, please, I'm here to repeat anything you want, as much as you want, but please, you have also copied all the lectures to the online platform. You can access it on your iPad, tablet, Android, Apple, computer, any platform, it's accessible. So if you want something, please don't take pictures, just ask me, and you will get the best of it. So what to expect on your end after you finish the course? You're going to learn the standards of communication skills, that's the aim of the situational judgment exam entirely. And that's the only core component that I wouldn't say we don't have. We all have it because we're all dentists by the end of the day. However, we just need to bring it out. And that's why I encourage people to go on cameras and face the instructor, the dentist, the patient, and get interactive. I know most of us are shy. Most of us are like, you know what, my English is not good. My English is good enough. I don't want to jump in now. However, you're going to have to make that jump. So the sooner you make that jump, the sooner you are ready to face the scenarios in the exam. And that's what the entire point of the exam is. So it's not just like the ACJ where you need to just do cases. Here, you need to feel them. You need to talk about them. You need to see what the patient is going to tell you. Other thing is you're going to manage different tempers and behaviors of the patient. So if the patient is mad, the patient is spoken, if the patient is scared, if he's knowledgeable. So these are different attitudes or different patient tempers of the same case. So when you look at the case, you read it, it's the same. But once you start with the patient might deliver their message in an angry way. They might deliver it in a scared way. They might deliver it in a very fluent way, or they might keep talking over you, then don't let you talk. So it's all the same cases. However, the approach is different. You're also going to be getting the necessary theory. So you don't need to go over too many books and too much theory. You're just going to go over the necessary theory for dental emergencies, because what's happening in the NDECC exam or situational judgment, you are getting dental emergencies. However, you're not getting the typical dental emergency. You might be getting something where the extremes of things. You're not going to get somebody who's just have diabetes. You're going to get somebody who might have like a higher end of, for example, the HbA1c levels, or the lower end of the HbA1c readings. You might get a person who has diabetes, but at the same time, they're coming to your extraction for emergency extraction. So now you need to check if they're controlled or not. So what are the questions you're going to ask to check if it's controlled or not? So we used to study in ACJ diabetes, when it's high, when it's low, what's the HbA1c levels, what it means to us, and that's nice as a theory. However, when you apply it into a scenario, you might get a patient who's like HbA1c is 8% in the last 3 months, and they're coming for emergency extraction. Versus the same patient who's having 8% HbA1c, they might come to have a filling. So the approach is different. How about a patient who's coming to you with HbA1c 8% in the last 3 months, and they're coming for a filling, and you did the filling and you're done? Patient is good, you are good, you're supposed to pass the station. However, you did not pass that station because you should have cared more about the patient, and you should have referred them to their physician to get a proper checkup if they seem to be not comprehending where they are in their own diabetes. How about a patient who's have HbA1c of 6% and they look pretty stable to you, and they're coming for an emergency extraction? So they're a stable patient, they're coming for emergency extraction. So absolutely, I will proceed with it. However, the patient is showing you sign to whatever you ask north, they answer south. You ask them, what's your HbA1c level? They tell you, oh, what is that? You ask them about their physician visit, they tell you, oh, what's a physician, for example, or we visited like 2 years ago, or I just moved to Ontario, I don't have a physician. So he looks stable, numbers look nice. When you do the glucometer reading in the clinic, it seems logical to do the filling. However, the patient is not comprehensive. He's not comprehending what you're saying. So in that case, you cannot proceed. However, are you going to proceed when the patient feeling pain? No. So as we can see, it's not cases from the ACJ where you just need to look at that case and solve it. You need to look at that case and you need to apply it to that patient, and what that patient might come up to you. So you might read in the case, HbA1c is 6, patient is controlled. And be like, you know what, emergency extraction, I'm ready for it. The way it looks to me, I'm going to proceed with that case. However, once you start talking to the patient might be like, you know what, he's showing me signs that he's tired. He's he's not comprehending what I'm saying. I'm sitting and talking to the actor, and the actor is showing me signs of not understanding what I'm saying. So I need to address these things. So that's what I mean. The case is literally the same for everybody. However, the behavior going to be faced behind that case is what's going to change. And that's what you're going to be getting here. And believe it or not, you cannot be getting that skill or that muscle of situational judgment exam without going interactive. So I always encourage interaction, because this is literally your only way. Some people, they learn the hard way. So they go to the exam, they know dentistry in and out. They know everything. They know all the articles. They know PubMed articles. They know DEX articles. They've passed the ICJ just this month. So they're very fresh. They go and they get sabotaged by the environment with the NDEB because they're not used to interact with a patient. And believe it or not, the NDEB are providing actual patients. So they're going to feel like actual patients. You're the one that's going to be anxious, and you're going to want to make that 10 minutes the most out of it. So at that moment, what are you going to be presenting? What's going to be available in your mind to present? That's who you are. So you need to be that dentist. You need to interact to build that muscle. So that's why I encourage, the sooner you take the course, the sooner you build that muscle, the more you can practice after, and the sooner you can get to the exam. If you delay that interaction phase of the course till the exam month or till the exam quarter of the year, so you're like, you know what, I'll decide to be interactive in the last 2 months, it is not going to be that much beneficial for you. All right, we move on. You're going to learn the patient diagnosis and treatment planning in phases, and they focus a lot on that within the situational judgment exam. You're going to learn also the RPD designs and prescriptions and writing, how to manage the patient pre-op and post-op, and how you start with them. Now, let's talk a bit about what's in the exam. So, exam is a 10-station exam. And once you go to the exam, there are 10 rooms. These 10 stations are going to be talking about 5 competencies. And what are those 5 competencies? These competencies are basically the ACFD competencies, the one we said that the NDEB came up with the ACFD framework for any graduating dentist from university or through the NDEB equivalency process. They need to have that framework. They need to be applying that framework to themselves when they're treating a patient. So you're going to have 5 stations, so 5 competencies, and each competency is going to have 2 stations. So you're going to have 10 stations in the exam. Each 2 stations are going to be talking about 1 competency. 10 stations, 5 competencies. You need to pass 6 stations out of 10 stations. However, you cannot fill 2 stations of the same competency. So you do have 5 competencies, 2 stations each, that's 10 stations. You need to pass 6 out of them and fail 4, but these 4, they cannot be 2 of the same competency. So you have to pass at least 1 of each of the 5 competencies. The exam is 2.5 hours long. It can be on your day 1. It can be on your day 2. It depends. Again, it's not a memorization exam. It's who you are. And that's what you're building here. You're building who you are. Who am I as Dr. Saif? Who am I as Dr. Rami? I need to be a better version of myself in order to go and be that doctor within that station. Within 10 minutes, what info are you going to be able to gather? What info are you going to be able to deliver? Is it the correct or the wrong one? And all you have is that 10 minutes. And here is the most common mistakes that people go through. Being shy versus being open, by the end of the day, is for you to make mistakes as soon as possible so you can avoid them to learn. So I do encourage people to go, and that is the reason why, because you're going to have to break that barrier in order to go and learn about the scenarios. Again, some people ask for a lot of theory, and it's not about the theory itself. It's about how you practice what you already have and be a better version of yourself. Some people might say, I'm not good in English, or my English is bad. And true. But again, those people, we did have candidates who just passed the exam, they tend to jump right through. And we did not have a really good prognosis, I would say, but they tend to pass because they did have a good way of delivering the message. When they listen, they have an active listening. When they talk, they have an active communication, effective communication. And effective communication is one of the 5 competencies that you're going to get in the exam. Some people might say, you know what? I will take the NDECC exam. However, I will focus on passing the skills and then do the situational judgment after. Why? Because the skills is like, it's a tougher exam. It's a more exhausting exam. So I will focus on that and then do the situational judgment. And you know what ended up happening? They end up passing the situational judgment course and failing the other one. Why? Because they were not too much invested in situational judgment. So they were not too scared or too anxious about it. So they ended up taking the theory and the way to practice from the course, and they have knowledge about it. They applied it once or twice. When they went to the exam, they did not have too much anxiety. So they just applied what they have, and they passed 6 out of 10 stations, and they passed the exam. Other people might say, I will practice alone, then participate. And that's like 99% of the people, and that's how they think. So I would encourage you taking the course earlier than later, because once you have the way of doing the cases or the scenarios, the more you can practice, the more you can build that muscle. The sooner you build it, the sooner you're going to get to the exam. And the way we're going to be doing things here, and that's why I asked Dr. Rami if he can open up their camera, is each station, or the way we're going to go through the course is, we're going to go through a dentist angle, and we're going to go through a patient perspective, and then we're going to go from an examiner perspective. And that's how the exam is. You're going to be sitting in a chair where you are the patient or you are the dentist, and then the person in front of you is going to be your patient, which is the actor, and then there's the camera, which is the examiner. So each one of us who's going to be taking the course are going to be doing the 3 roles, which is the dentist, the patient, and you're going to be an outsider looking at the dentist and the patient, and you're going to be the examiner. You're going to be checking what they're missing. You're going to be checking what they need to say, what they did not say. If it's a red flag, they will fail. And then this literally helps most of the people, the candidates who take the course with us, to understand where their issues are. So the more mistakes you see in front of you, the more you can avoid them for your own self in the future. So how are we going to study for the course? We don't need to forget that we are all already dentists. If it's not from Canada, it's from a different country. And that's why we're doing these exams here. So it's not, my part here is not to make you a dentist. My part here is to make a better version of who you are. And that's what situational judgment is. So the first week, how are we going to go through it, which is today's lecture. References will be sent to the ones who are going to be taking the course with us. And then we're going to go through dental scenarios today just to see how things are with you guys. and then we're going to go over the ACFD framework, which is that's the main part of the situational judgment exam. There will be a WhatsApp group where we send all possible scenarios for you, all the theory, all the articles, whatever we see important for you until you pass the exam. There will be a WhatsApp group dedicated for that reasons. And situational judgment exam is all about the concepts. And that's why I keep focusing on patient, dentist, and examiner, because it's not about the theory alone. It's about the concept. The more concepts you get exposed to, the more you're going to go through it without having to struggle where you have not heard about it. Now, ever since we started, I told you guys, we have a patient who have diabetes, and that patient have diabetes is controlled versus not controlled. So now you know the difference between the two. And I also gave you an example. You have controlled and not controlled. And at the same time, you have a filling versus emergency extraction. So it's mix and match. You can make your own case. So if it's uncontrolled diabetes, but you have a filling, you can proceed. However, it's controlled diabetes, but you have emergency extraction, which can also proceed. And we can add the third dimension, the 3D to it, which is patient is having slurred speech. Patient is having or showing signs that I'm not comprehending what you're saying. So when I get you exposed to these concepts, you're not going to fall into it again. So if I make up a case out of it right now, anybody would be able to answer back and say, oh, we know what that concept is. So the approach we're going to be using, which what we noticed that works for most of people, and this is not like my approach, this is not scholars' approach, this is an approach that's out there everywhere in any lectures that people attend, not just in dentistry, psychology, math, school, universities, they tend to follow an approach called the BST approach. And that's the first one we're using at Scholars Dental Situational Judgment course. The BST method is called the Behavioral Skills Training. So what it is, they notice that when doing that approach with any theory, so most of us, initially they attend lectures, just like this lecture. So most people are accustomed that through the lecture, they're going to be going through slides, they're going to be reading through it. However, there is no effective communication and there is no effectiveness in delivering the message to the audience. So what's the point of you taking a situational judgment course, but at the same time, you did not get my message of the exam? So I need to be showing you how the exam is going to be. And I need to do it in front of you, rehearse it in front of you and show you how an interaction is going to be. And then you have to repeat it in front of me. And then I have to give you my feedback. So that's the BST method that we're using. So you're going to see me doing an interaction with you. And then I'm going to model it with one of the doctors. And that one doctor is going to be a patient, is going to be a dentist, and is going to be an examiner. And then we will rehearse it again and again. And then I will give you my feedback. And that's where you're going to be able to see those 4 circles from all the 3 perspectives, as a dentist, as a patient, and as an examiner. Now, Rami, you are the lucky first one here. So what we have is the first example, which is the patient visits your clinic for pain in tooth 3-6 that wakes him up at night. The examination reveals irreversible pulpitis. Manage the patient. So now, as a fresh dentist who just started, for example, the NDECC journey, which is situational judgment and the skills, Dr. Rami, what would you think, just on the top of your head, what would you think is the issue here? So it's a 3-6 that patient has pain with that wakes him up at night. The examination did reveal irreversible pulpitis. So we already know it's a irreversible pulpitis. And they're telling you to manage the patient.
Yeah, so I think we would like discuss the treatment plan, whether like a root canal treatment or extraction, and like I don't know, would we ask about like the tooth Like,
just on the top of your head, like how, if you were sitting, I'm not here, I'm judging you, and I do really appreciate you going on camera because that's the only way to go with this course. So imagine Dr. Rami wearing that nice souped up scrubs with that nice souped up shoe. He's in a clinic and he gets greeted in their operatory. Let's call it operatory A. They go to operatory A and they see this patient, and that patient tells you, I have pain in my 3/6 and it's hurting. And then you look at the diagnosis from the previous dentist. Let's say it's a previous dentist who told you it's irreversible pulpitis. So, and now they're telling you manage this patient. So what are you going to be doing, for example? Just general highlight thoughts.
Like generally, I would ask about like the history of the chief complaint. How long has it been? And if you had problems with that tooth before. And like I'd ask about
Fair
the pain
enough.
more. And
That's nice.
what else? I don't know. Like, could you
and then you treat
remind
it.
me? Yeah.
Yeah. So that's good. However, now let's look at how things are, or how the model answers are. I appreciate it, Natasha. Good to meet you. So the first model, for example, let's look at the first model, how people might think. So thank you very much, Dr. Rami. For example, Dr. Rami mentioned we're going to see model 1, model 2, model 3, and model 4. We're going to see how people answer. And let's see where Dr. Rami's approach is. So patient has pain. So as a cause of irreversible pulpitis, people might say, since they're saying manage the patient, so we're going to go and provide management. So what is the management? Management is RCT, or other option would be extraction. Or some people might say, you know what? No, I'm not going to go that far. I'm just going to say RCT, because if that was my patient, I will do RCT, correct? However, did you make benefit out of these 10 minutes? No, you can literally say that in 30 seconds. Some other people might say, you know what? The patient experiencing pain as a cause of irreversible pulpitis. So I'm going to ask them, as Dr. Rami said, when did it start? Or have you had sensitivity on that tooth before? Any possible reason why this patient did not seek treatment when it was in the reversible pulpitis stage? So when did it start? We're going to ask that patient. Let's call him Dr. X. Patient X. Hey, Mr. X, like when did your pain start? It's like 2 months ago. I was like, okay, why didn't you seek treatment 2 months ago, for example? Oh, I just ignored it. So now the patient is giving me a hint that they are neglecting their oral health. So I would need to address that as well. So I cannot be just saying RCT. So what we're going to say is, have you had sensitivity on that tooth before? Any possible reason why this patient didn't seek treatment initially? Then provide RCT. So now, is model 1 and model 2 wrong? Like, is model 1 wrong compared to model 2? No, they're both correct. However, model 2 has more info than model 1. Let's go to model 3. Natasha, if you are ready, which is I would encourage you to be ready, if this was your patient, what would you do? Like what extra, let's stop at model 2. What extra things you would want to ask that patient?
Okay, by reading the question, I would start with asking about the pain and everything, but you confused me a little bit when you said that it's already diagnosed. So if it is already diagnosed, then I'm gonna go and again emphasize with the patient, like, I'm sorry that you're feeling the pain. We talk a little bit. I've done some researches. I have the diagnosis to tell you now, and I'm gonna take care of your pain today for sure. And thank you for being patient with me all this time. And then talk about the treatment plan, like the tooth is irreversible pulpitis. I'm gonna explain what that means. That means that the blood vessels and the nerves, everything like needs to come out. We are doing root canal treatment, or I'm gonna give the other option of extraction as well. And then tell him that like the benefits of root canal treatment and disadvantages of it, and then benefits and disadvantages of extraction as well. Ask him what he wants to do. It depends what his answer will be. Take care and manage of his pain that day, and then schedule for root canal treatment or extraction.
Okay.
This
So-
one was the fastest that I can.
Very good. Like
because
that's
I have
actually pretty
other
good.
things on my mind.
Exactly. So what Dr.
Natasha.
Natasha said is not wrong, and what Dr. Rami said is absolutely not wrong. However, let's look at model 3 and see where Natasha's answer is and what Dr. Rami's answers is, and then we can see what we're missing and what we can add. So model 3 is patient experiencing pain from irreversible pulpitis. We need to acknowledge their emotions because they're having pain. So I'm so sorry that you're feeling pain. I'll do my best today as a professional dentist. And all of these are magic words for me to memorize and learn. Like, I'm so sorry that you're feeling pain. My part here as a professional dentist, I will make sure I'll get you pain-free by the end of today's session. So now this is acknowledgement. We get the point of it. And then ask if they had sensitivity on that tooth before. So sorry, before I proceed with you, Mr. X, I just want to ask a question regarding that tooth. Have you experienced pain on that tooth earlier? Yes. When did it start? 2 months ago. What happened? So we ask these questions about it. We acknowledge first. Acknowledgement always comes first, and then you proceed with the other information. What else? Understanding limiting factor for the patient. So why did you ignore it then? Well, you know what? I was just busy that month, and I can't go. Like I finish work at 8 p.m. So now we know there is an obstacle for that patient, and we need to find a solution for that. So they cannot go to the dentist at 8 p.m. So now we need to find the dentist and provide them with their number on a printout. And we tell them that here is an emergency clinic that opens up 24 hours, for example. The NDEB is not going to care about where that clinic is and what's the name of them and if they actually open up or not. No, you're just going to be sending them that printout that's going to have information about a clinic that opens up late at night, for example. So all what the NDEB is going to care about is you providing like a solution for that patient. What else? Provide treatment options. So we're not just going to say, as the question is saying, manage the patient. We're just not going to provide RCT. We have to provide all the options that are possible. So we have RCT, and we have extraction, and we have no treatment. However, I'm not a big fan of saying no treatment because irreversible pulpitis, there has to be a treatment for it, or else the patient is going to lose the tooth in the future, or more pain is going to be exposed to the patient. Then we provide our professional recommendation because the patient likes, you know what, extraction is cheaper, so I'm just going to go with extraction. I don't want RCT. And imagine me being the tough patient who's like, you know what, Dr. Rami, no, I appreciate what you're saying. I know you're knowledgeable enough. However, I want you to respect what I'm saying. My pain is what I'm feeling today, and I want to treat it with extraction. But wait, why are you going for extraction, Mr. X? We have a better option for you, which is RCT. If you do it now, then you'll avoid extra payments in the future of having an implant, for example. So now it is going to cost you more than the RCT. However, it's not the recommended option. If you come to me as a professional dentist who wants the best for you, then I would recommend doing RCT. Like, that's fine. How long is the RCT going to take? 2 sessions. And how long is the extraction going to take? And you might say, it's a 1 session. We can do it today. You see, there you go. I'll just do it today then, because it's going to take 1 session. Again, Mr. X, if we do it today and we just take the tooth out, then this also will cost you other complications. So there are complications I'm going to have to bring it to your attention. So through the treatment complications and after treatment complications. Through the treatment complications, the tooth might break, adjacent tooth might break, we might break a bone, the tooth might crack, and we have a leftover of a root inside your bone. After the extraction, that space might close on itself. So you'd need either a space maintainer or you would need a definitive treatment, which is an implant. So that's going to cost you extra treatments and extra cost in the future. So how does that sound to you? Would you still want to proceed with extraction or want to do RCT? He's like, you know what, Dr. Safe, now that I'm thinking about it, I will just do an RCT then. And there you go. That's how you pass the station. So it is one sentence that says a reversible papitis, and they are saying manage the patient at all cost. However, what I might say to you as a patient is what can put an obstacle in your face. If I keep pushing towards extraction, then you're going to have to come up with a way where, you know what, if you keep pushing towards it, Natasha might say, you know what, I'll proceed with extraction. Rami might say, no, I'm not going to proceed with extraction. That goes against the non-maleficence, which is doing bad to the patient, and it goes against the beneficence of doing good to the patient. Then I will not proceed with that treatment, and I will choose to dismiss the patient. So in both of your cases, Natasha and Rami, both of them treated the patient. However, one of them proceeded with extraction, the other one referred for a second opinion, for example, or the other one dismissed the patient because they don't want to do harm to them. And that's how you pass that station. So that's model 3. You provided multiple options, RCT versus extraction, and you gave your professional recommendation, and you asked for their complication, which they said, we could not attend the clinic because we finished work at 8 p.m. You gave them a printout that says, we have a clinic that opens up till late at night, you can visit. So we solved that obstacle as well. So you did, in the last sentence, prevent this from happening in the future. Now, is there another model? This looks perfect to me. However, there is some extra candidate who will go and says other things. You gather all info from the pain, from the irreversible papitis, determine limiting factors and address them, gather info about their general health and their dental oral hygiene status. You know why they got the irreversible papitis and why they get the reversible papitis, for example. And then you do examination, which is what you should be doing. Take an x-ray and you explain to the patient what they have. So Mr. X, you have that tooth, which has irreversible papitis, how we call it in our dental word. However, in a simple language, irreversible papitis is an inflammation to the pulp, which is the internal part of the tooth, that is inflamed, and it's not going to get better in the future. It's only going to get worse. Oh, how come you're talking about that? How come I'm having that? Like, is it going to be better? I'll just take a Tylenol. I'm so sorry that you're feeling that way. I feel your frustration. However, it is what it is. We need to do the options to solve the tooth, to get you out of pain as soon as possible and to prevent further damage in the future. How does that sound to you? Sounds good. So what are my options? You go through the options. So always when there's a diagnosis, you need to say what that diagnosis is and why that diagnosis is. So what and why? So whenever they say manage that patient who has a reversible papitis, then I have to put it on the top of my list. I have to say to that patient what they're having. In a dental term, a reversible papitis. In a simple word to the patient, which is in layman language, we need to describe it because patients are not going to know what a reversible papitis is. Then you're going to go with them and you tell them what and why they have a reversible papitis. Then you present them with the treatment options and possible complications of each treatment options during and after the treatment. Then you get their informed consent. So model 1 can be done in 1 minute. Model 2 can take 3 minutes. Model 3 can take 5 minutes. Model 4 can take 8 minutes. The exam station is 10 minutes. So you will have time to ask questions and provide these answers. However, you need to be directed in the right direction. So there are 2 types of questions that we're going to go through. It's either asking questions or providing treatment. There are no other questions in the exam. So model 1 is correct. Model 2, 3, and 4 are correct. However, what's different is what information you presented and you asked within the treatment. Why? Because of the ACFD educational framework. And that's what it is. That's the entire situational judgment exam. They want you to be a competent beginning general dentist. Once you achieve that framework, then you can start in a real life clinic. The top and the foremost one is patient-centered care. Patient-centered care, you're going to see it in 90% of the cases. It basically means what it literally entitles. You're caring about your patient. The second one is professionalism. So patient-centered care is all the questions that Rami and Natasha asked. And the messages that they got from the patient, these are patient-centered care. Giving treatment options are patient-centered care. However, professionalism is Dr. Rami and Dr. Natasha being professional with the patient. How? By the patient saying, I want to do extraction. And they're saying, no, we will do RCT because it's better for you. This can also combine patient-centered care within it. However, by Rami dismissing the patient for a second opinion or refusing to do extraction, then Rami is being a professional dentist. Then after that, we've got the communication and collaboration. Is how we're gonna deliver professionalism and patient-centered care within our cases. This is basically communication and collaboration. Dr. Rami referring the patient for a second opinion, then Dr. Rami is dealing with the referring dentist, for example, which is Dr. Natasha. The referring dentist interaction with Rami and Natasha, this is called communication and collaboration. What do we call it in our clinics? Referral or referral letters, or you sending a prescription to the lab to do a crown for you. You took the final impression, you sent it to the lab. This is you doing communication and collaboration. You're collaborating with another facility, with another dentist. Then you've got practice and information management, which is you doing the record keeping, for example. After Mr. X leaves the clinic, you're going to go and you're going to put all the notes that happen with that patient on that record keeping, and you're going to do the progress note. Or you're going to be, Rami visited the clinic as a dentist, and the owner of that clinic is Dr. Natasha. The interactions that's going to happen between Dr. Rami and Dr. Natasha is part of practice management, which is practice and information management. How about health promotion? When Mr. X said, I did not go to the clinic because 4 months ago, 2 months ago, because I did not have the time, I worked till late at night, and you provided him with a clinic that opens up until midnight or 24-hour opening clinic, then this is health promotion. So in the same case, you might be faced with different competencies. However, I might be focusing more on my scheduled part of the case, and that station is going to be health promotion. I might focus more on extracting my tooth instead of RCT, and this is going to be a professionalism competency case. I might focus more on back and forth talks and what information you're going to give me. If you gave me treatment options, if you gave me 3 options, and you skipped giving me complications during and after treatment, or if you said the complications that can happen during and after the treatment, but you forget to give me the printout for the other dentist who's going to give me the second opinion. And this is basically patient-centered care case. So in the exam, you're going to have 5 of those. 5 competency, and each competency is going to have 2 stations. One station might be a role play. The other one might be written, which I believe that's what the pattern is. You're going to have 1 role play, 1 written out of each competency. Now the NDEB can do 2 role plays about the same competency also. So when going to the exam, the rule number 1 is to not judge that station based on its title. You're like, you know what? I feel that this is health promotion. Because once you're going to go through the process of saying this is health promotion, based on information you heard from that station or based on what you heard, then you might fall into the trap that the station is not health promotion, it was professionalism. And you said everything correctly. You said model 4 of that station. However, you were aiming more towards health promotion, but the actor was trying to push you towards patient-centered care. So do not analyze what the case is. Instead, ask questions and know exactly what they're asking you. And you have a patient in front of you. If anything you're not sure of, you should ask that patient, sorry,
I just have a question. So regarding your pain, before it gets to the way it is right now, when was your last visit to the dentist? He might tell me, you know what? It was a week ago. I was like, oh, okay. So in that case, then I'm going to be calling, I'll take your consent and reach out to the other dentist. And I'll try to take your records and see if they took an x-ray to see where things went wrong or why that filling is there. Because why did the other dentist ignore the reversible pulpitis and now the person has a reversible pulpitis? And they might tell you that. So, but the patient might also come back and say, oh, doctor, why did the other dentist did not see that on the x-ray? And now I think that the other dentist is not good. He missed it. He made a mistake. And you're going to fix it. Why would Dr. Rami fix a mistake that the other dentist did? What is the right approach in the exam to do that? Is Dr. Rami just going to say, oh, you know what? Yeah, I see the issue here, and I'm going to fix it. Yes, you're going to fix it. You're going to fix it for free because it's your dentist's mistakes. It's not mine. But Dr. Rami did not do the filling. He figured out that there's a mistake. He did not do it. Now the patient came here and he has that pain and it's due to another dentist mistake. It is a mistake. I can see there's a mistake there. Why? Because I gathered the x-ray and I was able to see that there is irreversible pulpitis. I can see there's a demineralization in the enamel and dentin. And I can see there is nothing done to that tooth. And there is no notes written about that tooth. So what went wrong? So the right way to approach it is, Mr. X, I would prefer for your best interest is to take your consent and refer you back to your dentist. So the other dentist can see what happened and give them the chance to fix their mistake if there is anything that was done. Because we don't know what the other dentist faced. Maybe the patient had trismus. Maybe they had limited access. Maybe they could not see it. Maybe the patient was coming about a filling in class 4 that did not require them to do any x-ray. Maybe the x-ray is old. Maybe they did not take it. So I would let the patient go to their dentist and fix their issue with the other dentist. I would not touch that patient. However, the other patient may come back and say, you know what? Dentist, Dr. Natasha from the other clinic who made the mistake, for example, I tried to reach out to them and she's traveling. She's outside the country. Okay, so exactly like Mr. X, sorry to inform you, but since your other dentist is not there, we would need to go through the routine protocol, our own standardized protocol of doing a patient clinical examination, and we give you the proper diagnosis and we treat you based on the fee guide that we have. No, but it's your mistake. The other dentist did it, and you're not going to pay for it. You're going to pay for it. I see how you're feeling, and I'm so sorry that you're feeling that way. I feel your frustration because we have to acknowledge what they're feeling. However, since the other dentist is not there, we have to act on that tooth because it's giving you pain, and I would not let you feel the pain by the end of this visit. So I would do my best to help you out here. So we were going to need to take another radiograph to check on what's happening if we did not have access to the previous one. Maybe we have access to the previous one and it's from a week ago. We can use that one. And we need to show the patient. So you can see here the white part and the dark part on the x-ray. So it shows that there is a demineralization. What it means is the minerals in that area demineralized, because patients do understand what demineralization is. They do understand what saliva is. We don't have to say spit. So there are things where are professional to say, and it's comprehended by the patient. And there are things that are very complicated: irreversible pulpitis, prognosis, periodontitis. We need to explain those words to the patient. So as you can see here, the demineralization went deep in the tooth, and now you're having pain, and that's the cause of the pain. So since your other dentist outside the country, we need to take action on that tooth. What the action is, we're going to have 2 treatment options for you: RCT versus extractions. Complications that can happen during RCT is 1 to 3. Complications that can happen during extractions are 1 to 3. However, my professional opinion is to do the RCT because we can save your tooth for the future, and I can see the tooth is restorable. How does that sound to you? Sounds good, doctor. I will go with that option. However, I just lost my job. I don't have much in my pocket, to be honest. And I paid for that treatment, and the dentist outside the country, like I'm literally cannot. pay the entire treatment fees for the root canal treatment. So can you please do it for free? Is there such an option in dentistry to give treatments for free? What do you guys think? Rami, Natasha, Dr. Anisa. Do you think we can give a treatment for free for such patient who had a negative experience with the previous dentist? They did not have the best treatment by the previous dentist, but their dentist outside the country. Now they're coming for RCT with us, with you, but they're telling you like, we agree with you. I believe you and I see you're professional enough to get me out of pain. And I love the way you're treating me. However, I don't have money to pay. I lost my job. Do you think the right option is to provide them what they want, is to provide a free treatment?
I think that that we cannot provide them with free treatment, but we can certainly send them to the community clinic or a clinic that can provide something for them. For free.
So you're going to provide them with an option.
Yes.
To go into for a public clinic, for example,
Yes.
or a public health clinic here in Canada, and they can go through a free treatment there. But is that free treatment going to happen today, or is it going to take a month, for example?
Yes.
It's going to take some time because the list is big on public health free care.
Yes.
So, but this patient is having pain.
And here I'm not sure. I think that we can do some like as a clinic. If I go with that option, that my clinic is providing sometimes the free treatment, then needs to be like registered as what is it called? Pro bono. I don't know.
Yeah.
Like pro bono.
No, I see your point.
I'm not sure. Am I allowed to do free treatment? But that will like I need to document it and be in
No, fair enough. I see your point. I see where you're trying to head with that.
Yes.
But this patient today have pain. They have irreversible pulpitis. They cannot sleep at night. So is it logical that we're going to send them to a public health clinic?
So we can certainly do pulpectomy.
Are you going to do pulpectomy for free? Dr. Rami, would you do pulpectomy for free?
Him something simple. We can ask him how much you can pay, how much you can afford. We can certainly talk with the office manager and make some plan for installments for you to pay the minimum that we can do it. Or
that's
again,
also a nice approach.
My question is, are we allowed to make it for free and document it as it was a job done in like again, I don't have the. It's not like
it's a nice approach. I like that approach. You need, like you see, you need to like get those thoughts and you know what's right from them. Dr. Rami, what do you think? Patient has irreversible pulpitis. He's in a lot of pain. He does not have money.
Yeah, I think what Dr. Natasha said, I would go for a pulpectomy or pulp extirpation, and then I would refer the patient to like those insurance for low-income people, and then he can like come back once he has insurance if he's actually saying the truth that he has.
So literally what you both guys said, what Natasha said and what Rami said are correct. What Rami said is we need to get them pulpectomy for free, for example, and then we need to ask them if they're able to find a program for low income or something. And then what Dr. Natasha said is we're going to get them pulpectomy, and then we can later do it for free for them and put it in our notes that it was done in good faith, for example, because other dentist made a mistake or something. The combination of these two answers is almost not fully correct, is almost correct. The answer for the NDEB, they do not want to hear from you that you're doing a free treatment. And this is one of the most famous traps that you might face in the exam, is a free treatment. They would love to hear that the first from you. Like once they see it, they will take it on you. So there is no free treatment. And that's rule number one. Rule number two, patient cannot at all costs leave your clinic with pain whatsoever. The first option we're going to give with what Dr. Natasha said to the patient who does not have money is to give them a payment plan. How much are you willing to pay today? Are you willing to be on a payment plan where you pay a part of the cost today, and then later on next month, you can pay the rest of it? And most of the time, patients are going to be agreeing with that. But then Dr. Rami also said another thing, which if the patient did come back and say, I don't want to pay anything, I don't have anything to pay, not even a payment plan, then we can do what Dr. Natasha said by putting it in our record keeping, saying the patient did not pay for it and we're not going to pay for it. But we're going to go back to what Dr. Rami said, and we're going to try to give a printout to the patient about eligible programs that they might be eligible for. If he's on a low income, if he's in Canada and he lost his job, then he might be eligible for EI for income. He might be eligible for low income, Ontario Works. There are too many programs that we're going to go through the lectures where they're going to have access to it. And this is all part of health promotion. So Dr. Rami's answer is correct, half of it. Dr. Natasha's answer is correct, half of it. They both would not pass this station because at some point, one of them left the patient with pain. The other patient did it for free, for example, initially. However, the other patient who also failed said, we're going to go and find, for example, treatment plan for them, which they can find an eligible dental program. And the other patient who also failed, sorry, the other dentist who also failed, said, we can find a payment plan. So the answer to these questions, no free treatment, that's first of all. Patient cannot leave feeling pain. This is like a red flag. You cannot finish the 10 minutes, patient feeling pain. If it what takes you to do a free pulpectomy, this time only, and then the next appointment, please do your best to pay, is also an answer that's going to save you in the exam. And through the course, we're going to be learning strategies how to cover yourself in the exam. So in case you had to go to the free treatment, what can you say to cover yourself? In case the patient had to leave the clinic without you doing the pulpectomy because they have an uncontrolled diabetes that you cannot touch, and they're coming for an emergency extraction. So that's what the exam is. Emergency extraction, which means you have to act today on it. But he is uncontrolled diabetes. So he's uncontrolled, I cannot proceed. And it's not a filling, it's an extraction, and it's emergency, then I cannot proceed. Then what am I going to do? I will give painkiller, and I will refer the patient to the hospital today, to the emergency. So no matter what, the patient has to leave your clinic with pain managed, with his oral status managed, with their general health managed. So that's why we're going to be sending that patient to the hospital. They're going to take good care of them there. So at no cost, at no scenario, you will let that patient go feeling pain. And no free treatments. Keep that in mind. So these are the 5 competencies. We literally did the 5 competencies now in a single case. However, how would we know in the exam if it's one of any of those competencies? We would not know. We literally would not know. So don't focus on which competency that case is, because that case could be a reversible pulpitis, which is patient-centered care. However, it could be professionalism because the patient said, I'm going to do extraction. However, it could be communication and collaboration because I need to refer them to their previous dentist. And it could be health promotion because I need to find a plan for them. It depends what they're asking you or what the aim of that station is in the exam. But something I can tell you, do not let any word slip out of the actor's mouth without jotting it down on your paper because you need to talk about it. If I say I'm busy, I said I'm busy. You need to manage that busy word for me. If I said, I don't like, to be honest, whenever I brush, I'm having bleeding, so I just don't brush. You're not just going to focus on me not brushing. You're going to focus on my emotions, because I might show you that, I'm caring for you. I see your frustration. I feel that you're saying that you're feeling pain. So I'm so sorry about that. And I'll do my best to help you. All right. Next. The first competency and what it means. So it's the application of professional knowledge, skills, and values in the profession of patient-centered care. That's what it is. Whatever we're talking, most of it is patient-centered care. And basically, that's going to be in most of the cases. Everything we're going to be talking about is going to be mostly patient-centered. Your approach to get the patient pain-free is patient-centered. Your approach to get the patient diagnosis, you explain it to them, is patient-centered care. You reaching out to other dentists to care about the patient is patient-centered care. But you reaching out to the dentist is communication and collaboration. So that's how we're going to base it. Anything we need to take care of that patient is going to be patient-centered care. So what does it include? What the NDEB wants from you? Interpret the findings from the patient's chief complaint, medical, psychosocial, and dental histories, along with the clinical, radiographic examination and diagnostic test. So they want you to do a proper questioning, investigating, and clinical examination, and you give the diagnosis. So you go through it all. They need you to develop treatment options, which is what we said, RCT and extraction and no treatment, based on the evaluation of the patient's data. So all the scenarios you're going to be going through are going to have all of those things. Recognize the relationship between general health and oral health. What does that mean? Can somebody think of something that has to do with general health and oral health? Smoking, I would say. Smoking would have an effect on oral health, but at the same time, it would affect the general health. So they want you to know the link between multiple things that can link oral health to general health. So, hey, doctor, like I brush my teeth every day and I smoke and my teeth are white. So why are you telling me to stop smoking? I don't have gingivitis. I don't have periodontitis. My teeth are white. I brush 5 times daily and I'm good to go. Yes, but I see where you're coming from. And I do encourage you to keep doing what you're doing when it comes to oral hygiene. That's a pretty good thing to do. However, that might affect your general health, because smoking can affect your lungs, can increase the incidence of you having, or the chances or the percentages of you having cancer. You're going to be more prone to have asthma and COPD. It can affect your heart. You might have bacterial endocarditis. You can have too many things that can affect your overall general health. So I agree with you, your oral status is in good condition. However, it might affect your general health. So NDEB, they also want you to see, they might throw something in your like an obstacle that shows you that it has no implication orally, but it might have an implication on the general. You might have a patient who wants to do RCT without a rubber dam, and they have asthma. So I tell you, doctor, like if you're holding the clamp with the floss, so what are you scared then? Like I have asthma, I don't want to use the rubber dam on my face. It will suffocate me, for example. So true, we are scared of the clamp, but just to let you know that the rubber dam, we actually use it not just for the clamp, we use it also for the material and the instrument we use for during your root canal treatment, which can irritate your airway, and that will agitate your asthma as well. So we are doing it for you because we're a professional dentist and we care for your oral health and general health. Check, I just passed that station. So everything the NDEB wants you to do is basically the ACFD framework. You obtain the chief complaint, medical, psychosocial, and dental histories. Then you perform a clinical examination. What else? Assess patient-specific risk factors for oral disease or injury. What was the... So if you read this sentence, where is it related in the case that we just studied? The assess patient-specific risk factors for oral disease or injury. Can you remember, guys? Rami, Natasha? Do you remember when did you speak about patient-specific risk factors? Which was that patient who did not come to the clinic because he has work until 8, correct? So
Yeah.
that one, yeah, that one is considered a patient-specific risk factor, which is not negligence. They're not neglecting their oral health. They just don't have the time. So this is a risk factor for them. So we need to address it. If you don't address it, you did not achieve the framework. And now the framework made you fail because you did not check that one off. Develop a problem list and establish diagnosis. I believe everybody who finished ACJ know what a problem list is. It's just a list that has an X-ray and all the items that has issues with it, from caries to calculus to missing tooth to supernumerary tooth to impacted teeth. Develop appropriate, comprehensive, prioritized, and sequenced treatment plan. I might come to you, I want whitening, but you see that I have calculus. So might tell me, hey, Dr. Saif, I know you want whitening. However, not to sabotage you, we will get you the whitening. However, we need to do cleaning first. Now, this is just in simple words. So the NDEB is looking for you to have a sequenced treatment plan. I want to have an implant here. Yes, but you have a tooth there that is not restorable. We need to do the non-restorable tooth first, and then we can do the implant after. Yeah, but he's a smoker. So we have to do cleaning. We have to do the extraction. We have to wait for a month or two. We do reevaluation of the oral status. And if he responds to smoking cessation, we can do phase 2, as we know in the ACJ, which is the definitive treatment. Correct? So that's what it means here. Appropriate, prioritized, sequenced treatment plan. Recommend appropriate non-surgical and surgical therapy for caries management, RCT versus extraction. Provide therapies for preventions of oral disease or injury. We're going to talk about this later, which is the caries risk assessment, the CRA, which is the one that is used by the NDEB is the ADA, the one by the American Dental Association. Manage an anxious or fearful dental patient. I want to go through RCT. However, I don't like needles. What I'm smelling in the clinic is not something I'm comfortable with. It agitates me. Why? Because my wife had a root canal treatment and she smelled the same thing. She experienced the same needle and she did not have the best experience. We need to manage that. Manage conditions and diseases of the periodontium, which is any perio issue that we're going to be dealing with. Manage partially and completely edentulous patients. And that's what we're going to be doing with RPD designs. There's no complete denture design. The more obstacled design is basically the RPD, which we're going to be taking along the course, the RPD design in a very simple way and method. Manage odontogenic and non-odontogenic pain and dental emergencies. Reversible versus irreversible, extraction, RCT, these type of emergencies that we're going to be dealing with. And again, we said we're going to have an emergency faced by a controlled patient or an emergency faced by an uncontrolled patient. One, we're going to proceed with it. One, we're going to refer to the physician or refer to the hospital. Manage complications, outcomes, and continuity of care. You might get a case where they say the patient has been going through extraction of an unrestorable tooth and the root broke inside the bone. So break the bad news to the patient. So we're going to have something called breaking bad news to the patient. and we're going to deal with it. So I'm so sorry that you're feeling pain right now. However, I just want to let you know that, as you are aware of, your tooth was severely decayed, and we were doing the extraction. However, as part of the complications that we already let you know about it, because we said in the treatment plan, we're going to let them know about complications during and after. So as part of the complication that I did let you aware of it prior to the treatment, unfortunately, the tooth broke, leaving a small piece of the root inside the bone. We did attempt to remove it. However, we were unsuccessful to remove it. The patient's going to be like, oh my God, what happened? Like, how come did this happen to me? I'm paying money for this. I cannot have this happening to me. Then we can literally let them know that we are so sorry. We acknowledge their frustration. We are so sorry that you're feeling that way. And as a professional dentist, we will make sure we do our best to get you pain-free and to get you going for that root tip that's remaining in your bone. However, we cannot do it in the clinic. So we absorb all the negative energy from the patient, we let them relax, and then we go back to them. So now we need to manage it. So what needs to be done? We need to refer you to a surgeon, and that surgeon is going to be taking care of your remaining tooth tip that remained in your bone. After that, you should be good to go. If you have any other questions, let me know. However, I will give you a printout that has all the information that we spoke about and the referring dentist. How does that sound to you? Do you have any question? We always follow up by saying, do you have any question? Okay.
Do we do the pain management and antibiotics for that one?
Of course. So that's going to be part of your printout. You're going to tell them if they're in pain, if they're going to go to the reference dentist today, if they're going to go tomorrow, if you sutured it back. There are too many details about it. If it's they're going to go today and they're feeling pain, so what's going to happen today is we're going to give you the referral letter. You have an appointment with the specialist at 2 p.m., for example, in 2 hours from now. However, in the meantime, I will prescribe you Tylenol, which is a painkiller. You're going to use it when there is pain, and this is just to manage your pain for today until you get to the referring dentist. How does that sound to you? Sounds good, doctor, but like, can you give me more information? Sure, I will give you a printout that has all the information. The printout is something we do not forget, and this I tell something to my candidates all the time. Printout is not something I compensate at all cost. If we're talking about an appointment, I will give you a printout. If we're talking about a referring dentist, I'll give you a printout. If we're talking about like a post-op instructions after extraction, I will give it to you as a printout. If I'm talking about a clinic that opens up until 12 a.m., I will give you the address and the phone number in a printout. Go over it, read it, and if you have any question, I'm here to help. Ask me. And the actors do love that. So we should always put it on our list. And basically, everything we said comes before the consent. Once we say all of that, you say, how does that sound to you? Sounds good, doctor. Can we proceed? Can I please get your consent? Sure, that's my consent. It's your part to determine when consultation, referral, and other diagnostic testings are indicated. So for example, when do you refer? You refer if an endo failed. What do a general dentist do in the clinic when it comes to treatments? Do they do regular RCT? They do. Do they do RCT on a molar? They do. Do they do a retreatment of RCT? No, they refer to endodontist. What if there is a separated instrument in the root? Do they do it? No, they refer. So it's common sense. And that's what the NDEB, they want to see as well. They want to see a safe dentist. They want you to see, they want to see that you are not jumping into all treatments. Hey, doctor, so for that missing anterior tooth that I have, I was born without that tooth. So what do I do? And the age is 25, 28. Blunt. I like that option, doctor. So how do you want me to do it? Like, do you think like it's going to be good if I put it here? Oh yeah, it's going to be good. How is it going to look, doctor? Like, is it going to be long enough? How far are you going to go into the bone? Are you going to drill my bone? And now we're going to start answering questions about implants. But is it your part to do implants? No. It's not part of the general dentist, because we cannot forget We are talking about the competent in the middle here, the competent beginning general dentist. The competent beginning general dentist is not going to do RCT. It's not going to do implants. So, hey, doctor, like I have these 2 teeth. Can you please extract them and put all on 4? A hybrid denture that goes on 4 implants? Oh, absolutely. That's a treatment option. So how many implants are you going to put, doctor? Since we all dentists, we all know what all on 4 is. So we might say we can do an all on 4. However, how many are you going to put? I might put 4 if I would do implant. However, I just failed that station because it's not my expertise. It's not my scope of dentistry to provide how many implants I'm going to be placing there. Do I know the thickness of the bone? Do I know the density? Do I know the medical history? How can I recommend how many implants? And I'm not even started taking a course in implantology. So the things that we need to be smart in what we say. We do pulpectomy. We do RCT. We do crowns. We do bridges. We do impacted teeth. But we do not provide a distoangular impaction treatment. We do not provide proximity to inferior nerve block teeth. We do not provide retreatments to RCTs. We do not retrieve roots from the bone. So we need to know the fine line between referring and not referring. And even when you refer, you should refer and ask the referring dentist to bring you back the patient after for maintenance. In the exam, we're not going to think about only what that patient in that sitting is going to do. We have to think about what happened before to lead to this and what the patient is going to do after to prevent it. So whenever I say I'm brushing twice daily, I would recommend to brush 3 times daily. But why did you brush twice? Oh, because I have like a brush that's so harsh. I don't like the feeling of it. Now there's a misconception. There is something that's wrong that the patient is using. We can correct it. So what do we do now for the recession or the damage to the gums that's been caused by that harsh brush or the stiff brush that the patient was using? We're going to have to schedule him in the next 3 to 6 months where we can have another session to check on that patient to see how the gums are. If you're having sensitivity, we can apply desensitizing agents. We can provide a fluoridated toothpaste to get you out of the sensitivity you're feeling. So that's what the exam literally is. It's not patient have pain, I will treat you and bye-bye. Like that's not how it is in the exam. The exam is literally, so that's not how easy it is. And it's not very complicated where I don't know what to do with you. No, it's literally an interaction between you and that patient. What ball are going to throw at you and how are you going to face it back? RCT? Sure, I will go with RCT. Do I have another option? Yes, extraction. How much is it? It's almost, we cannot say the dollar amount. We don't know the exact dollar amount. We can say it's going to cost cheaper than the extraction. Sorry, cheaper than the RCT. Okay, then in that case, doctor, I'm not really like, I don't really have money. So I'll just have enough to do extraction. Can we please proceed with extraction? If this was my patient, not even the NDEB, I would do my best to help them financially and get them to do RCT, not extraction. And that what the NDEB when they see. They want to see that you're a safe dentist who's assisting patient, not for free, but treating their pain and giving them options to pay. So that balance. And in everything you guys think about in all of the scenarios, dentistry is not black or white. Dr. Rami might say, I would check what he's eligible for, and I would do it for free. Dr. Natasha might say, I might refer him to a public health clinic. So there is no right or wrong in both of the answers, but what answer left the patient without pain management and what answer did the pulpectomy for free? So there's no black or white. It depends on that examiner, what obstacle they're going to throw in your face on that specific station and how you're going to respond to it. But if I would tell you now, you know the concept of payment. Can you make another mistake with the payment? If I come to you again now and tell you, hey there, I don't have money to pay. What is the first thing you're going to tell me? Payment plan. That's what you guys have in mind now. What if payment plan does not work? We'll see what programs you're eligible for. You said you lost your job. Are you actively searching for a job? Yes. If you're a low income, there might be a program eligible for a low income. If you are a recent immigrant, there is a program that is eligible for immigrants for the first year, correct? That they can use as a dental program. What if it's a kid who is less than 17 years old or less than 12? Then there's a program called Healthy Smiles that might be eligible for up to 12 years of age. So there are too many programs that we're going to go through and their details, and each patient is going to be using their own. What if they're 70 years old and they have a disability or a stroke that they experienced 3 months ago? Then they're eligible for disability programs. So there are too many programs that we're going to go through to manage those patients, but the concept is what matters. You know, there is nothing called a free treatment. So what are the types of questions in the exam? It's one of the two. Nothing else. It's either gathering information. I'll give you what pain I have, and you're going to have to ask me questions about the pain. Or I will give you the pain I have, and you're going to have to manage me. So it's either gathering information or managing the patient. So what do you see in the cases? Patient has a reversible papaitis, manage the patient. So this is management. What if you spend 8 minutes asking questions? Is it wrong? Technically, it's not wrong, but are you going to pass the station? No. What if they're telling you gather information and you spoke 5 minutes, 7 minutes about RCT versus extraction? Is it wrong? No. You also solve the case for the patient. However, that's not what the NDEB wants from that station. They want you to ask questions, gather information. And you spent it saying RCT versus treatment. You told them about the complications, what social history they can avoid. Here is a printout for you. Can I get your consent? You went far there. You went far in the management. But the question is literally gathering information. Gathering information has nothing to do with management. I'm just going to ask you questions. You're going to answer me back. I'm going to jot them down on paper. And that's it. Thank you very much for your answers. We will see you later for management. That's it. The case is done. Okay. And hence, we have our friend, Socrates. Has anybody heard about Socrates? He's the famous philosophy. So they're saying to move the world, we must first move ourselves. And the first two that I see here that move themselves is Dr. Rami and Natasha, which is good for you guys, because that's what I emphasize the most about. Interaction, interaction, interaction. The sooner you are jumped into interaction, the sooner you can clear the situational judgment. There is absolutely no other way but for me to be mad at you, and then you're going to face me back. I will tell you I don't have money, and you're like, I will give a payment option. I don't have any money at all. You're going to have to come up with another thing. And I will keep talking. I will keep wasting your time, and you still have treatment options to deliver to me. And I will make sure I waste your time more. I'm like, hey, Dr. Rami, thank you very much for coming to my clinic. Like I can see that like I brought my kids here and my kids are liking the environment at your clinic. And like treatments here are nice. I saw the advertisement on the TV and things look very cool in this clinic. You guys have like way too modern devices here and things are cool. And be like, you're trying to give me the treatment option as in Dr. Rami. And I'm like, yeah, we'll get to that later. That's fine. However, things here are cool. Like, can I bring my wife again? And there's my in-laws. They would love somebody who's as professional as you are to take care of them, because we want a dentist who's as professional as you are, as caring as you are. We want you to take care of us. Is that fine? Let me just call them up. And I keep wasting your time. And time is ticking. You have the 10 minutes. You have to deliver your message. If you don't deliver treatment options, extractions versus RCT, if the examiner does not hear you saying these two words, then you lost that station. I want to do like my orthodontic treatment. I've been saving for it. I've been working with the community work labor here in Ontario, and I've been raising a lot of money, man. I bought this nice car, and I bought a house, and now I'm saving to do my orthodontic treatment, and I'm here for you to do that. So I wish you can help me with it. And you start to talk. I'm like, yeah, so my other friend who also had that tooth, but you know what? He ended up doing ortho, so his teeth ended up being like kind of crooked. So I'm not sure how I feel about that. I really want to do it. And you start to talk and be like, you know what? But what if my tooth gets resorbed and I keep wasting your time, for example? So you have to manage my expectation. But like, so sorry to interrupt you on what you're saying, but there's something really important that I don't want you to miss. And that's something important is about your teeth. So in order to go through orthodontic treatment, we're going to have to take preliminary x-rays to see what's happening. And everything. But doctor, why are you interrupting me? I'm trying to talk to you. I understand what you're saying. However, let's talk about the important things about your oral health, how it can impact your general health. However, everything else we can talk about later privately in my office, and we can talk about everything else. How does that sound to you? Oh, sounds good, doctor. And these are the obstacles. I'm gonna give you like a case. You're gonna talk to me about it. If you see me, I'm too scared. Like, I don't want you to put amalgam. I actually have an amalgam on my tooth and I want you to take it out. I don't want it in my mouth. And you come and check out my tooth and you see that amalgam is in good shape. It has mesiobuccal, distobuccal, the buccal cusps, anatomy at its finest. Things are nice. I don't want that filling. I want you to remove it. Because I don't like amalgam because it has mercury. And mercury can cause systemic toxicity. I'm pretty sure, doctor, you know about systemic toxicity, right? If you get such patient, then he's an eligible patient. So yes, you're not going to be like, we cannot remove it because it looks good. You have to give them an actually knowledgeable answer. And that knowledgeable answer is going to be, we cannot remove it because clinically this is acceptable and it looks nice. However, if I try to remove it, it might put you under the risk of too much exposure of the mercury that you're talking about. So true, there is a mercury exposure risk. However, it's not yet confirmed that it can cause toxicity. It's only for those who have systemic toxicity and allergies to mercury, for example. And that's, or hypersensitivity to mercury. So you give them, they face you with knowledgeable and scientific information. You have to face them with scientific and knowledgeable info. You cannot just give them a regular answer. What if I'm a patient who tells you, you will remove it? I'm a dominant patient. I'm sorry to interrupt you. I just don't want you to miss anything important. I do agree with you. I see that you want to remove it because you want to make it look better. However, this will put you at risk, so I will not remove it because I want the best for you. And we will get over those personalities. So literally, the same case line you're going to read is going to hide 4 different types of personalities behind it. And each one of those, you're going to know how to answer them. But in general, you're going to have 2 types of cases. Either gathering information or management. If I tell you gather, then I will tell you how to gather. And if I tell you to manage, you will know how to manage. However, if I tell you manage, this does not mean you don't go and gather information. This means you go and you pick a point or 2 from gathering information and you come back to management. Because you might need, you will treat RCT for that irreversible pulpitis. But how would we know when did it happen? So when did it happen? 2 months ago. So we have to ask a question. When did it happen? Why did you ignore it? So this is asking questions. However, I cannot be invested in asking medical history, dental history, social history. We cannot be invested there. We have to ask, sorry, before I proceed, I just have a question or two I need to ask you before I get to the management. Is that okay? I always ask and confirm. Yes, that's okay, Dr. Saif. Sure. So my first question is, when did you feel that pain? Oh, it was like 2 months ago. What happened there? I was eating, and suddenly when I was having like cold water, I have sensitivity, and then just ignored it, to be honest. I'm just too much busy at work. He said too much busy at work. So I will just put it down on paper. Okay. And yeah, so now I'm here and I'm having that pain that makes me not sleep the night. Oh, I'm so sorry about that. We acknowledge, but we did not forget what we asked there. Then we go back to the management. All right. So your treatment options are 1, 2, 3. The complication that can happen is 1, 2, 3. I will give you a printout that has all the information we spoke about. However, I will go back to my question. However, just something to bring to your attention. We do have a clinic that opens up until midnight, so which is an option that I can give you for next time to avoid these episodes from happening, so you can take good care of your oral hygiene. How does that sound to you? Oh, sounds good, doctor. While if you did not say that, the NDEB is going to look at it as, I gave you information as an actor, and you ignored it. And all the patient said is literally, it happened 2 months ago, and I ignored it, to be honest. I'm just busy at work. You can just overlook it and move to management. And that's what I mean by do not ignore any word that the patient says. All right. So back to our friend Socrates. This will be your friend to pass the exam with situational judgment. Does anybody here over the call, you can raise your hand if you are not too sure if you're gonna open up your camera or not. Is anybody aware how Socrates is going to be applied to our cases? Rami, Natasha, are you guys aware how we're going to apply it? Have you heard of it?
Yeah, I don't know much about Socrates, to be honest.
Okay. This is actually something we're going to be using. It's not just used in dentistry. Again, this is part of the BST method that we're using here. It's not just something in dentistry that they use. They use it everywhere. They use it at hospitals. They use it in physicians. And we're going to use it as well in dentistry as part of information gathering.
For pain.
So he said, to move the world, we first move ourselves. So you need to move ourselves to be as interactive as we can so we can get this exam going. So his name is Socrates, S-O-C-R-A-T-E-S. But in order to go through those, start them. We're going to start by gathering information. So we said we had 2 types of questions. We have questions that are gathering information, and we have questions about managing the patient. So literally, the only 2 questions you guys are going to find, either manage the patient or gather information. If I tell you he has RCT and it failed, manage, it's a manage. If I tell you the diagnosis is reversible, then I told you the diagnosis. Then they're going to tell you explain management, perform management, advise patient about payment options, all about management. If I tell you he's some type of soccer player and he fell on his tooth and there's no management, then I'm going to have to ask about questions. When did it happen? Did you go to the hospital? Did you take an x-ray? Did you go to the dentist? Asking questions. So it's something we will not forget is our friend Socrates. Gathering information through Socrates. So Socrates is a mnemonic acronym used by emergency medical services, physicians, nurses, and other health professionals to evaluate the nature of pain that a patient is experiencing. So it's been used everywhere. And believe it or not, you're going to thank me later that there is some person called Socrates who's having such service for us, because you're going to be using this in the clinic later on. What does it include? So that's how we're going to break down Socrates. S-O-C-R-A-T-E-S. It's for patient-centered care. The S from Socrates is about the site. Hi, Mr. Rami, how are you? Can you please point out where the pain is? And Mr. Rami is going to have probable pain in his 1-1. He's going to point out that's where the pain is. So we're going to talk about the site. Can you point it out? That's for the S. How about the O? It's for the onset. So when did it start? Was it gradual or sudden? Is it like a crown of fracture due to crack tooth syndrome? Or is it like a sensitivity from cold water? So that's the onset. So what is the characteristics if it's a C? Is it sharp or dull pain? If it's reversible pulpitis, it's going to be sharp pain. If it's irreversible, it's going to be dull pain. Sharp pain that lasts longer. Okay. How about the R? Radiation. Does it radiate elsewhere in the mouth or in the face or in the body? Like, is that pain getting referred? Sometimes they tell you, oh, we have back pain. It might be a referred pain from somewhere else. They might tell you, oh, yeah, it's not just dental pain. I have like a pimple on my gum inside my mouth. Oh, does it radiate elsewhere? Is there another one that looks similar to this elsewhere? He's like, yeah, I have one on my lip as well, external. I have one on my chest, for example. So that's for aphthis, for example. How about if diabetes, if they already have diabetes? Is there somebody else? Of course, he's not going to have it inside the mouth and outside the mouth. But how can it radiate? How can diabetes radiate? It can radiate, for example, goes to a family history. So, for example, we're going to ask, is there another family member who has diabetes? Oh, yeah, my mom and dad both has it, for example, so they got it from them. So that is characteristics. How about A, association? Is it associated with bleeding, with the swelling? Is there bad taste? So these are the association from Socrates, the A. What about the T? What is the time that this happened? Does it wake you up at night, or is it better or worse at night or in the morning? T at the same time can mean temperature. So are you experiencing any fever? What about the E? Exacerbation. So what makes the pain better and what makes the pain worse? So for example, doctor, you know what? Like I usually have like a cold bottle of water, and it helps me with my pain. So if they say that, what type of pain do they have? That means they have irreversible pulpitis, because usually gets better, the pain feels better on cold water because of the gas shrinkage. How about the S from Socrates? The S is a score of pain. So from 1 to 10, how would you rank your pain? Oh, it's 5. That means it's moderately tolerated. Oh, doctor, it's 9 out of 10. Then what are you going to answer that? Oh, I'm so sorry you're having that pain. I'll make sure as a professional dentist take care of you by the end of the day. So this is Socrates, and that's how we're going to ask questions about it. And this is only for the chief complaint. If I tell you a person is having irreversible pulpitis, ask questions, then the first thing you're going to ask is Socrates. This is something that's going to become part of your routine. It's about pain. You ask Socrates. If it's about a disease, you ask about the Socrates. If it's about like a tilted tooth, a cracked tooth, if it's anything, the chief complaint in your case is going to have Socrates. Now, all the time you're going to ask about all Socrates, Socrates, not all the time. You might sometimes within the management, we said we have management and we have asking questions. Sometimes if your question is management, you might want to know a thing or two from Socrates, and then you get back to management. So sorry, before I interrupt and go into your treatment plan, however, I have a couple of questions to ask. Is that pain just recently started? Can you please point it out? Is it better at night or in the morning? Do you feel any metallic taste in your mouth? Any fever? Is it better at night or in the morning? What makes it better? What makes it worse? My son have like a thumb sucking habit. So what makes that better? What makes it worse? Usually when he's watching TV, he does not do it much. However, if he's in bed, he does it more often. So you can apply it here. However, I cannot be like, where is your son sucking their thumb? Because it's not a site. Onset, I can say, when did it start? So Socrates is an overall something for you, so do not forget, is when you ask questions about any case. However, if it's pain, then all of it is going to apply. And most of our work in a dental clinic is about pain. So if it's pain and it's information gathering, Socrates is your friend. And Socrates, if you want to put it in apostrophes, Socrates is about the chief complaint only. All right. Now, on that note, and before we take cases for the day, we're going to go on a short break for 10 minutes, and we're going to get back at 12:15 Eastern time. So we're going to get back in literally 12 minutes. Alrighty, so take some breath, refreshen up, have a cup of water and coffee, and let's get back here. We're going to do more practicing. See you guys.
Alrighty, guys, we're back. We'll wait for Dr. Rami and Dr. Natasha to join in on their camera so we get to start with our first example. All right. Do we have any other participant who wants to be part of the scenarios? All right, Rami. Seems like you're the lucky one, which is good. Okay, so you got the point behind the Socrates, correct? So that's how we're going to use it, and it's mostly used for asking questions. So anything that has asking questions, then it's going to be mainly Socrates. So for example, if you get a patient in the clinic, then what do you think, in your own words, what do you think is the sequence from the patient enters to the patient leaving your clinic? What do you think is the right approach, or the steps, or the sequence of those steps to get that patient going? If you would think about it, like if I was your patient and I just got to your clinic, what do you think is the best sequence for me, from me being to the reception until me leaving the door to go home? So I would come to you in the reception saying, I want to see Dr. Rami because I have a pain on my tooth, and they tell you, okay, let's see, and then they get them to your operatory, and then Dr. Rami now is seeing the patient. What is the first thing you're going to ask? We said.
I would follow the Socrates. First, I would ask about his pain. I guess like the receptionist would tell me he's in pain before he comes into the clinic.
Exactly. Yeah.
Yeah, and then I would just follow the Socrates.
Sure. So that's regarding the chief complaint. What do you think comes after the chief complaint?
The treatment options.
No. So treatment, you're ready to give treatment. But now you only know questions about the chief complaint, which is the pain itself. You got the score, you got the Socrates, the onset, the characteristics of it, if there's fever, if what makes it better, what makes it worse, you got all of those. But how about after the Socrates? Like what are we going to ask about? We need to ask about the general health, which is the medical history.
Oh yeah.
True. And then after that, we got to know about their medical history. What's left after that? So we got the medical history. We need to go through. We need to go the dental history. So we go through the sequence of management, not the sequence of gathering information. When I say, we said we have gathering information, and we said we have the management. So gathering information is going to have Socrates, going to have medical history. And after the medical history, they're going to have the dental history. And after dental history, we're going to go, as Dr. Parshant said, we're going to have the social history. And then after the social history, we gathered all types of histories. Now we're going to go with the examination. So what comes after the examination? We got to know why. We got to know the diagnosis.
And as we said in the beginning of the lecture, for diagnosis, we're going to go through what and why. So what is the diagnosis and why did it happen? We're going to say these two to the patient. So the patient now got to know what is it and why it happened. Now, what is the next thing we're going to be giving to the patient? The treatment options that we spoke about. So now if we would go about it again, we've got SOCRATES to gather information about the chief complaint or the history of the chief complaint. And we've got the medical history. And then we have the dental history. And then we have the social history examination. And then after the examination, we've got the diagnosis and why it happened. And then we go to treatment options or management. So these are almost like 7 steps. If I tell you, ask questions, you're going to ask questions about SOCRATES, medical history, dental history, social history, and you do examinations. And then you stop there. If I tell you explain management or explain diagnosis and do management, they're going to explain the diagnosis and go through management. So any case I would give you right now, if I tell you manage the patient, you're going to have to go through the last 2. And any case I tell you, which is that the BST approach that we're using, the behavioral skills technique, if I tell you ask questions, they're going to go through the first 5. If I tell you manage the patient, you're going to go through the last 2. Now, if you go to the last 2 and you want to ask questions, you have a question here or there. You want to check the medical history, we check the dental, you want to go to social, or you want to go back to a question or 2 from SOCRATES. You're going to be like, you know what, before I proceed with your treatment options, I just have a couple of questions to ask. Is that okay? We ask for confirmation. I'm like, yes, sure. You go back to SOCRATES and then you go and ask. So now, what do we ask from SOCRATES? SOCRATES, basically, we're going to go through the SOCRATES. Once we finish those, thank you very much for your patience. Thank you very much for your answering the questions. Now I just want to have a question regarding your medical history, for example. And we ask questions regarding their medical history. So anything that we need to be aware of, any medical condition that I need to be aware of. When was your last visit to the physician? Is there anything that you want to tell me? Are you having any signs of symptoms? Any medication? And you ask them about their general well-being. You ask them about a stroke history, cardiac issues, lung issues, liver issues, kidney issues, bone issues, allergies, anything that has to do with medical history, and we're going to go over them one by one. And if we had to go through further questions, and now we finished with the medical history, what comes after that is the dental history, as we said. So what is the dental history is going to have? Dental history is going to have, when was your last visit to the dentist? What was done on your last visit? How are your brushing habits? Do you have any metallic or any funny taste in your mouth? Do you have any prosthesis that you're using in your mouth, like an appliance or denture? And this is basically their dental history. Are you flossing? Are you brushing? You got the dental history. Thank you for your patience. I'm just going to ask a couple more questions regarding your social history. So we said we have SOCRATES, we have medical, dental, and now we have social before we go to the examination. So regarding your social history, what do we ask in social history? Any smoke? Any alcohol? Do you drink? Do you smoke? Any sugary drinks? Any fizzy drinks? Any sugar drinks? Energy drinks, for example? How is your diet like? Do you usually have a balanced diet or not? Are you usually having a stressful job? This is the social history. Thank you very much for your answer. Now we'll proceed with the examination. What are the examination that we're going to do? We're going to have the extraoral examination, and we're going to have the intraoral examination, and we're going to have the X-rays or the radiographs, and we're going to check the occlusion. And this is basically for your examination. Thank you very much. Once we get the examination done, we'll get back to you with the findings. How does that sound to you? Sounds good. Thank you very much. So this is basically the asking questions part of the question. And then after that, you'll get the management that you want. So if I tell you that's the case, ask questions, then you're going to go through these questions. If I tell you that's the case and go through management, you go through the management itself, which is what and why for diagnosis and the treatment plan. What if I tell you, or what if you feel that you have a question or two you need to ask from the asking questions part? They'd be like, sure, before I proceed with the management or with the treatment options that I need to tell you through this case, I just have a question or two regarding your medical history. Is that okay? They'll be like, sure. So we're going to go through a question or two from the SOCRATES, a question or two from the medical history. Is there anything that I need to be aware of? No. How is your brushing habits are? I brush 3 times daily. Thank you very much. Now I can go back to my management answer that I want to. So now, Dr. Rami, if you would wrap it up in a simple word. If you receive a patient to the clinic, from they enter to the reception until they leave the door, smiling and happy because you treated them in their best way possible based on your own experience and your scope of practice, what are the sequence of treatment or pathways that the patient is going to go through? Now the patient is at the reception.
Yeah, I'm just gonna repeat what you mentioned, which is first we start with the SOCRATES to gather information about the chief complaint, and then afterwards we'd ask about the medical history, and then afterwards we'd ask about the dental history, and then after that we'd ask about the social history, and then we'd give them the diagnosis. We'll present them with the information. And then we'll present them with the treatment options. And I think I'm not sure if I missed something.
You did not miss anything, actually. Pretty good job. In the end, you're going to ask about the consent, which is part of the treatment options. Like once you tell you manage, then the last part of the management is going to be the informed consent. So if I tell you ask questions and get informed consent, they're going to ask those questions. And the last thing you're going to say is, can I get your consent? Because once you say, can I get your consent, and you say any information after that, it's not going to be part of the informed consent. Informed consent is a process. Once the patient knows in and out of everything, that's when they go through the informed consent. So now, if I would tell you the medical history, what does it contain?
Are you asking me?
Yes, Dr. Rami. If I would tell you medical history, what is it going to contain? When was your last medical checkup? And if there's anything that you need to be aware of, any medical condition that you should be aware of, any medications, if they're taking, any allergies, and any hospitalization that happened recently. This is the magic 5 questions regarding medical history. However,
sorry.
Go ahead.
Would they give us the medical history form, or do we have to memorize these questions?
So these questions, so what I'm giving you right now is literally what's on the form. Now, are you going to get the form in the exam? Probably not.
Oh, okay.
Not probably. 99% not. When are you going to get the form? You're going to get the form if there's something specific about the form. For example, if I tell you, you have a patient who's having irreversible pulpitis, presented to you with this form. How would you manage? You would need to look at the form and see what the patient have checked. But the things the patient might have checked, might not have checked, is what I'm telling you here. So if there is if they tell you, ask questions regarding the pain, they're going to go through SOCRATES, correct? If I tell you, ask questions regarding medical history, and the patient has no medical issue. However, you want to ask questions about medical history in general. You need to ask questions from A to Z. A to Z is basically you have to ask me from head to toe. This is the easiest way. So we're going to start with the head, and here we're talking about medical history. So for medical history, after we finish Socrates, so for example, if the question was manage the dental pain or ask question about the dental pain, and the patient have diabetes, then we are going to ask Socrates about the dental pain, and we're going to ask only 5 questions about the diabetes, which is, when was your last visit? And by the way, this is diabetes and any other condition. When was your last visit? Are you taking medications? Do you have signs and symptoms? Are you taking any medications for those signs and symptoms? Have you been hospitalized? Is there somebody else in the family who has it? And then we ask them, last question is, anything else that you want to tell me? We give the actor an opportunity to help us if there is something they can help us with. Now, this is us asking about a specific medical condition. And in this case, it's diabetes, for example. But what if it's no diabetes and no medical issue, but they want you to ask and check on that patient's medical history? This is a different scenario. You have to ask from A to Z. So A to Z from head to toe. We're going to start with the head. What are the possible things that can happen to the head? Strokes, concussions. Any recent stroke or concussion? Like, no. Just short and simple. Without, have you ever had an issue with your brain, like a stroke or like hematoma or like a hyper? We don't go through the long process of asking questions. Like short and simple. So we're just going to go with any recent brain issue, like stroke. So brain issue, like a stroke. No? And then we go down to the thyroid. And we're going to ask questions, any gland issues, any hormonal issues? Yes or no? Then we're going to ask about the heart, any heart issues like hypertension? No. Any lung issues like asthma? No. Any liver issues like hepatitis? No. Any kidney issues? No. Then what's left? Digestive. Any digestive issues? No. What other things left in the body? Bones and muscles. Any bone issues like arthritis? Any muscle issues with or without example, doesn't matter? No, 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 no. Thank you very much. The last thing is superficial stuff, allergies and infections. Any recent allergy or infection? Yes or no? And if the patient was a woman, there will be some female-related questions. Any pregnancy, any hormonal changes, are you on your period? And all of these questions that has to do with females. So if I tell you, discuss or ask information, if you notice that this question is generally about asking questions, they're going to have to ask everything. If I tell you this question about a person who has diabetes, then you will not go from head to toe. You will ask the magic 5 questions regarding diabetes only. And we're going to go through it all. But that's the difference. And this is just part of the medical history. How about after that? We're going to go through dental history. So for dental history, what are the things that we need to ask our patients for? This is basically not even for the exam related. This is like you in your clinic. Am I your first dentist? Or you've been to a dentist before? So basically that question in a professional way, when was your last visit to the dentist? Are they a new patient or are they a returning patient? Like for cleaning or like a recall appointment. So the first thing you're going to ask, when was your last dental visit? How are your brushing habits or oral hygiene habits? Do you brush, floss, use a mouthwash? I don't brush. I floss though every day, but I don't brush. Then I keep in mind that he does not brush. I keep it down on the paper. What is the third thing? Do you have any appliance in your mouth? So a denture is an appliance. A filling is an appliance to begin with. So appliance means anything in the mouth, a dental appliance. So when was your last visit? how are your dental habits are, any appliance in your mouth, and is there any funny taste in your mouth, for example. This is all dental related stuff. What's left technically from this patient, we knew about their pain, we knew about their medical history, we knew about their dental history. Now what's left for us is to know how this patient is living their life. If we want to know about their social. So what's social? Any alcohol? Yes or no? That's it. We're not going to be like, how much alcohol you're drinking. Any alcohol? Yes. How often? Occasionally. Thank you. Any smoke? We're going to go through the smoking part. We're going to jot it down on our paper. What's after that? Any sugary drinks? Do you consider yourself having a stressful life? Yes, no, yes, no, yes, no. You got the social history as well. We call that social history. What's after that is basically examination. How are we going to go through the examination? We said we have extraoral, intraoral, radiographs, and occlusion. Now, this is the normal sequence of a patient interaction. A to Z, asking questions. And if I tell you management, you're going to start A to Z in the last two steps, which is the diagnosis and why it happened, and then the treatment options and the complications of them, and then the famous printout that we're going to give to our patients. And we're going to go through an example now. So, exercise scenario 1. A 17-year-old male comes to your clinic as a new patient suffering from a dental pain. Ask questions and gather information. And we're going to welcome our first dentist, who is going to be Dr. Natasha, to the clinic. And she's going to be taking care of the patient, which is going to be me. And I have dental pain. And the question is, ask questions and gather information. So you will have in the exam 13 minutes. The first 3 minutes is going to be about you writing down what you want to say, what points you want to tackle. And then after that, you will start within 10 minutes. Now, if you were not ready in the exam within 10 minutes, and if you're still writing things down in the exam, can you still utilize 1 minute or 2 from the 10 minutes and start in the minute 8? Yes, you can. You can just let the actor know that please give me an extra minute or 2 until I'm ready to start. And they're going to happily do it because you will have 8 minutes only to solve the question. So Dr. Natasha, I'm here. I have dental pain. I want you to ask questions and gather information.
Hi, Dave.
Hi, Dr. Natasha. Thank you for coming to see me.
Yes. Hi, Dr. I'm sorry that you're today in our clinic with the pain issue, as I can read from the document you sent from the front. Can you tell me more about it? What's happening? How we came here? How did you came?
Thank you very much for that question. Actually, yeah. So I have pain on my tooth here on the lower left side. So this actually started like what, 2 months ago, and now I'm having a lot of pain about it. So
I'm
yeah.
sorry that you feel this. During our talk, I'm gonna write some information that you're telling me. It's just for my documentation.
Sounds
and
good.
I'm gonna make sure today to relieve your pain. But I know I need to go through some of the questions so we see what makes you feel this.
Sounds good.
And how can we help? That's okay with you?
That's okay. That's fine. Thank you very much.
Okay, so you're saying this pain started from 2 months ago?
Yeah, I was like, actually, it comes and goes every now and then. However,
And
I keep having, whenever I'm having food, I feel it. So now I'm not even like bothering much.
okay, and the constantly in these 2 months is the same pain, or this today, yesterday, this couple of days?
It's just the same
worse than
pain. It's
the
just
pain?
sensitive. That's what it
Okay,
is. Yeah.
so why did it took 2 months for you to come here? Is
Actually, yeah, I just was hoping to come last 2 weeks, but I called the clinic here and you guys were very busy and I got busy too. So I just had to wait until I get an appointment. So I'm not sure you guys are very busy and that's what it looks like.
Apologize and thank you for luckily found place for you today and thank you for coming in and getting out of your schedule. But let's get back to the pain. You said that it's in the lower part.
Yeah, it's here on the lower part.
Okay. Did something relieve your pain? Do you take any medication for that pain, or just it comes and goes when you're eating?
Yeah, I take this. You guys call it Tylenol. I got it from Walmart. I'm taking 3 pills actually every 5 hours, and it's relieving my pain. To be honest, yeah.
Oh, it relieves the pain for 5 hours and then it stops. When was your last time you take the Tylenol?
Oh, I took it literally like 3 hours ago.
Okay, so now
Yeah.
do you feel pain or not?
It does reduce my pain, yeah. But again, like whenever I have like a cold drink, it like jumps on me, so I'm avoiding anything. Sometimes even cold air would give it sensitivity.
Okay, and do you know specifically which tooth it is, or it's just on the right side?
It's that one. Like I believe it's you guys call it like a molar. It's on the first one. Like it's the first large one.
On the scale from 1 to 10, do you know?
Now it's nothing, but when I have like cold water, it's like 9.
Oh, 9. That's very intense.
Yeah.
Have you been to the? Oh, my goodness. Have you? Is this your first visit for this tooth? Have you done? Have you visited some other dentists for this tooth, or is your first?
No,
visit?
it's just the first time I'm coming to this clinic, to be honest, and I'm hoping you guys can help me.
Okay, sure. We're gonna do some X-rays later to see what they did, and I'm going to do some clinical examination in your mouth as well, and then luckily we're gonna get to the diagnosis of the tooth. But in the meantime, I need to ask you a little bit more about your health. So, do you have any medical condition that you can tell me about it?
Okay, sounds good. Thank you very much, Dr. Natasha. We can keep going, which is this pretty good. I'm actually impressed. However, why would you? I would not say why would you not pass. Why would you fail? Actually, why would you fail this station? Because the question is ask questions and gather information, and we are only trying to go about the pain, not management, not treatment options, not examination.
Okay.
So that's what I mean when the question is gather information. You can gather information only. You can spend time to treat me, which is nice. It's not counted towards your case in the exam.
But I was short on the questions for the pain.
Yeah.
I didn't know what to ask anymore about the pain and about the tooth
Yeah.
to go. That's why I went on medical.
Exactly. So that's the best thing to do. Is I felt that, of course. I saw it with you. The best thing to do is to go one by one through Socrates. So put your head, okay, the S. We're gonna go for S, the site. So, and it's okay if you want to practice, you can say it. We're gonna go through the S, the site. So can you please point it out?
Okay.
Then the O, the 1 sec. When did it start? Just short and simple. You don't have to elongate the question. When did it start? Can you point it out? Then the C, is it characteristics? Is it sharp or dull?
Yeah.
And then you go through the R. Does it radiate elsewhere in the mouth or in the face or in the body? Yes or no? And then we go the A, which is the association. Is it associated with any bleeding, smell, taste, you know? And then you go through the T, which is the temperature or the timing. Is it better in the morning or at night? Any fever? Yes or no? If there's fever, that means some acute infection that's happening. Then what's after the T? We're going to go with the E. What makes it better and what makes it worse? I tell you, you know what? Cold water makes it worse. Not eating and hot water makes it a bit better. And then you're going to have to go to the S, which is the score, which is what you asked. So what was missing here is you jumping from 1 to another, which is fine if you can handle the entire Socrates, because it's not related to the sequence of it, but it makes you forget about other parts of it. However, what Socrates is going to help you with, the examiner is going to be probably holding an iPad, and whatever you ask, they're going to try to check it if it's on their iPad. So the Socrates, if you go with that in sequence, which comes by practice, and that's what I mean, the muscle you're going to treat with, that's what's going to get you the pass. Is you don't have to sweat solving the question. You just have to go through the BST approach, the structured approach, and they're going to be checking things off for you on the iPad. And it's going to help you not forget about the things you mentioned in the exam. Okay? And we cannot leave Socrates. So let's say you ask the score, which is the last question in Socrates, correct? You cannot leave from Socrates without having a general image and a possible diagnosis. So what is the patient talking about here? What do you think the possible diagnosis is? Exactly. However, if you ask just about the intensity, and because I helped you, because through the case, I was telling you on cold water. Through the case, I was telling you back and forth. However, I was not asked about what makes it better and what makes it worse initially. I had to provide it. I was not asked about, I was asked about, for example, when it started, so 2 months ago. But I gave you the hint that it's a reversible pulpitis. You should have got the question that gets you that. So if you think that there's some possible diagnosis with that tooth, then you have to ask questions regarding that from Socrates. But we cannot move to medical history without having a general idea about what the diagnosis is. Why? Because that's the chief complaint, the history of chief complaint. All righty. Thank you very much for your questions, Natasha. However, I'm here and I'm like to get my medical history. So Dr. Rami, can you please proceed and ask him about my medical history? So how would you take the patient from Natasha, and you are the second dentist now, Rami, who is going to be dealing with me? So imagine I'm a real patient in front of you.
So do I just start with asking the questions, or do I have to like introduce myself first?
That's what I mean. So imagine this is a real patient in the clinic and you were just talking to Natasha. Now I'm talking to Rami. So thank you very much. Like say for your patient with Dr. Natasha. However, I'm going to proceed and ask you about questions regarding your medical history. Is that okay? So a fluid transition between communication. And this also applies if you got a new patient versus you've done the examination and now I need to tell you the diagnosis. That means I already greeted you earlier. So now I cannot be like, hey, how are you? My name is Dr. Rami. No, I cannot do that. I have to be like, thank you for your patience. So now, further to our examination, we got the findings, and I'm going to break down the findings for you. Is that okay? So you got what I mean, Dr. Rami? So yeah. You have to make it fluid. The transition is fluid. So now I'm talking to Dr. Rami. I was just talking to Dr. Natasha. So please proceed.
So I introduced myself as Dr. Rami, or
yeah.
Oh, okay. So hi, I'm Dr. Rami. Nice to meet you. I just have some questions regarding your medical history, if that's okay with you.
That's okay. Please proceed.
So when was your last medical checkup?
It was actually 3 months ago. I'm pretty good active, like when I go and get my blood checked and everything at the physician.
Oh, was it regarding any specific medical condition, or was it just a
good question? Actually, no, it was just a regular checkup. So I just got my blood work and check and all that.
Oh, okay. Do you have any other underlying medical conditions that you would want to tell me about?
I believe I'm fit and healthy. So that's what, yeah, I'm good.
Oh, okay. Are you taking any medications or any supplements?
I do take vitamin C, actually. Not sure if that affects much, but that's the only one along with vitamin D.
Oh, okay. Trying to think of other medical questions. You said there were 5.
Yeah. What do you think related is here? Technically, you have to go be like, thank you very much for your answer. I just have more in-depth questions I'm going to ask you about, which is any a brain issue, any hormonal issues, any
Oh.
heart issue. Because here,
Yeah.
I'm telling you, I'm fit and healthy. I don't have any general issue. Like I'm in the case, I'm not having diabetes, for example. If I had diabetes, only 5 questions. Medical
Oh, okay.
checkup, blood work, symptoms, medications, hospitalization, these type of things. However, if I'm not having anything, then I have to go through the questionnaire with you, which
Like
they call it the review of system.
Okay. So the first one was
We
there
go
any
from top to
brain?
bottom. Brain issue, yes.
Oh,
Any brain issues like stroke?
oh yeah. But this patient is 17 years old. So would I still ask about stroke? Is that okay?
That's a medical checkup, medical questionnaire.
Oh, okay. So and then after that you ask about the thyroid, right?
You go, yeah, from top to bottom.
So do you have any thyroid issues or any hormonal issues?
Actually, I'm good. Yeah. I
Any
try to get
problems with
my balance,
breathing?
like my healthy diet all the time. So everything is in check. Thank God. I'm good. I'm not sure I need to ask all those questions.
That's okay. That's good to hear. Do you have any problems with breathing or with asthma?
No breathing actually, doctor. But I literally don't know why you're asking all those questions.
Just like this is just protocol for our medical history. So we
Okay.
ask these to all our patients, even if they're healthy.
Oh, fair enough. Please proceed then. Thank you very much.
Do you have any digestive issues or any issues with your?
No digestive like issues. No, I'm good. No lung issues.
Okay. And no issues with your muscles or bones or anything.
Sometimes I do like some pains in my legs when I walk, but I'm not sure. I thought of like visiting the physician later on for that, but I just didn't have the time to.
Oh, okay, that sounds okay. I don't know, doctor, is there anything else I'm missing?
That would be it. Allergies, medicine.
Oh, allergies, yeah.
Infections. So allergies, medicines or meds, infections, and then any female issues if the patient is a female.
Oh, ask if she's pregnant.
Yes, exactly.
Oh, okay.
If you're done, make sure you close it smoothly.
Okay, thank you for your time.
And thank you for your patience. Thank you very much, doctor. Yeah.
Yeah.
Sounds good.
So,
Natasha, proceed to take the patient from Rami. Dr. Rami, you're going to be doing the dental history. So what are you going to ask in the dental history?
I asked. Okay.
So am I the patient or the dentist?
You are going to be the dentist. I'm the patient. You're always going to be the dentist here.
Okay. And now I need to take the dental history?
Yes, because we said we have the history of chief complaint. We've got the medical history, dental history, social history, and then the examination.
Okay. Yeah. So you said that you have this pain for the last 2 months. I'm just curious. Am I your first dentist that you're visiting? That you had a dentist?
Yeah. I'm actually, yeah. As you can see in the case, Dr. Natasha, I'm here as a new patient to your clinic.
Oh, okay. What was your last time visiting the dentist?
Oh, I'm like a year and a half ago, I would say.
Okay. And was that visit was a provoked visit as this with the pain, or you went for a cleaning and a regular checkup?
No, I just took my kids, to be honest. I just took my young daughter.
Oh, so
Yeah.
you were not the patient, you were just visiting the office just for your...
Yeah.
When was your actual last visit to the dentist, for cleaning or doing some dental job?
It wasn't for myself, it was for my daughter, so that's what they went for cleaning.
Okay. And then can you recall when you were last visit for yourself?
No, can't really remember, to be honest.
Okay.
I usually just go for my kids. Yeah.
Okay. And how is your how is your oral health habits? Like, do you brush? Do you floss during the day?
I do brush. Yeah, I do brush 3 times.
3 times in a day. So that's very good. And do you floss?
I floss as well. whenever I can, like once a week, twice a week.
Okay, but not every day when you're brushing and flossing.
No, yeah.
Do you have any issue in your like except this thing that you're now feeling? Any taste in your mouth or something else?
Yeah, I have a filling on the other end.
Oh, you have.
I had it when I was young, yeah.
That's from a young age. You haven't visited. So you don't
Yeah.
have any recent visits. You don't have any recent X-rays or checkup with the dentist.
Yeah, I'm not sure what you mean, yeah, but yeah, I haven't.
Okay, and then
Doctor, I'm not sure. Do you need to ask all those questions, or because
yeah,
I'm just for that pain that I have on my
yeah, I'm
tooth, and
just
I'd appreciate
making
if you just
sure
make it
that-
quick so you can treat me.
yes, but I'm just making sure to get clear. How can I help you in the best way for you? So this is just every. No, I'm stuck here.
Okay.
Okay.
Make sure you close it smoothly.
Yeah.
It's okay to pause. It's okay to take a pause. Think what you want to say and then say it. If you don't have anything, be like, sorry, I cannot help you. I'm going to refer you to my friend who is a dentist. His name is Rami. He would be able best to help you now. Always make sure you have a smooth going conversation. If you know how to, and if you don't know how to, it's a communication skill you need to have. You cannot just keep it weird, just close there with, I don't know what you want to do.
Okay, so thank you for all the answers that you give me. We're gonna proceed a little bit further with my colleague now to come and take care of your specific thing that you have for today. And thank you for asking for answering all the questions that I.
Thank you very much, Dr. Ash. I appreciate you. Thank you very much. So yeah, Dr. Rami, so I'm not sure what Natasha was saying, but can you please like not ask those questions and we can just proceed to the treatment? Like my tooth is hurting.
Yeah, I understand that, like, because of the pain, you're a bit impatient, but we got to go through all the steps before we can proceed to the treatment.
But that's,
So
I
now-
just signed that the complaint, like whatever you guys call it, well, the consent, and I'm good to go.
Okay. So, but first, I think, Doctor, are we in the examination part right now? Are we done the dental history?
Yeah, I believe she was asking about dental history, which I don't know why. I'm just having pain. I just want to be treated, to be honest. So I would appreciate if you just take it, fast track it, and get me treated, please. And I believe that's why I'm here in the clinic.
Yeah. All right. Well, we're almost done, and we just have a few more steps to go through and a few more questions, and we're just gathering information so that we can provide the diagnosis and the treatment options to you.
Because it's safer for me, because you're a professional dentist and you think it's safer for me to ask those questions.
Yeah.
Okay, fair enough. Thank you. Please proceed.
Okay. So, doctor, what step are we in right now? Like, are we in the
if we finished the dental, what's left?
examination?
No, before examination, we've got the social history.
Social history, yeah. So the patient is 17 years old. So would I still ask about smoking? Because
do 17 years old not smoke?
I mean, they're not allowed, they can't buy it.
True.
So,
you still have to ask.
Okay.
They can always say no.
Do you smoke?
No, not at all.
Okay. Do you drink alcohol by any chance?
Yeah, I do.
Oh, really?
Yeah.
Oh, okay. So what do I do if I
bad?
I mean, if you're 17, yeah, it's kind of bad.
You should still ask and then provide your consultation.
Oh, okay.
So how often?
How often do you drink?
Actually, occasionally, sometimes with my friends, because sometimes they try to push me to drink, like peer pressure through friends. They always try to get me there. And it tastes good, to be honest. It doesn't affect me much. But I'm almost close to that age, so why not?
Yeah.
Acknowledge it. Do not leave it hanging.
So how would I acknowledge it, doctor?
I see. We're gonna get to that later. We just have to talk about something else, and we're gonna get to that part later. So what we need to do now, anything else regarding your social history?
So what other questions were in social history? Smoking,
Any sugary
drinking,
drinks, stressful life, stressful environment.
Stress. Are you experiencing any stress in school?
Actually, I believe life is just stressful in general. So that means there it's a general answer that they're not too much stressed, but that's how life is. But I do have lots of sugary drinks and coffee.
Okay.
Yeah, it keeps me awake, to be honest. I have a lot of exams, so coffee and sugary drinks, energy drinks is what gets me through the day.
Okay. Well, I'm gonna note that in my notes because that's a big factor when it comes to your oral
Okay.
health.
Okay. Thank you very much, doctor. So I need to acknowledge it, close it, and move on.
So then I would say thank you for your time. Thank you for your
And thank you for your
patience.
patience. Exactly. Now we're going to proceed with
The examination.
examination. So you need to tell me what you're going to be doing in the examination. We always tell, show, do. We have to tell the patient what we're going to be doing with them. So we're going to be going through the examination, which is going to consist of extraoral examination. So I'm just going to check your lymph nodes to see if there is anything related on your face. And then we're going to check intraorally to see any like vitality test to check on that tooth, to see anything related. We're going to take an X-ray or two as needed to provide a better diagnosis for the tooth. And we're going to check your occlusion. Is that okay?
So we just
okay.
say it. We don't actually do it in the exam.
In the exam you don't do it. Actually, in the demonstration for the exam at the NDEB location, you're going to be greeted by the chief examiner, and they're going to tell you, please do not reach out to the patient to see what's inside their mouth because it's not an actual patient, it's just an acting patient. But you're going to have to tell them what you're going to be doing.
Okay.
Sounds good. So that's the examination. Once we've done the examination, we're going to get back to you with the findings. Thank you very much. Is there anything you want to ask me before we close? No, that's it. Thank you very much. And that's how we close it. So now this is asking questions and gathering information. So let's repeat what the question is. 17 years old male comes to your clinic as a new patient suffering from a dental pain. Ask questions and gather information. So ask questions and gather information. We said it's from chief complaint SOCRATES to medical, dental, social examination. We closed it there. We said, thank you for your patience and thank you for answering the questions. We understand you're frustrated. We understand you're having pain. We'll make sure as a professional dentist, we will take care of you. How does that sound to you? Sounds good. Thank you. Thank you very much. What is the next question? 17 years old male comes to your clinic as a new patient suffering from reversible pulpitis. Provide diagnosis and treatment options. And that's how the questions are in the exam. So how are we going to go about it? Where are we in the spectrum of asking questions and management? Are we in the initial part or are we in the second part?
The second part, but again, we need to.
Yeah. So here we said provide diagnosis and treatment options. So here we're talking about we've done the examination already.
So we don't start with like so then we start after the examination and from what you been asked and answered, we got to the diagnosis. Just
you've got it. Yeah. So that's how you start.
That you have a reversible pulpitis, and then do you know what that means?
So what did we say about diagnosis? What we're going to say in diagnosis?
What is given to us, reversible pulpitis.
Yeah, but what did we say we're going to talk about? What two things? We're going to say what is it and why it is.
And why it happened. Yeah. We're going to explain what it is to the patient.
But how are we going to greet it? So thank you very much, Natasha. You're my dentist and I'm the patient. And now you're starting with the case and now you have 10 minutes, for example. You started the case. How are we going to start talking?
Okay, so thank you for being patient and waiting for me to come and answering all the questions that previously I have asked. And
exactly. So you're not going to start with, oh, hi, my name is Dr. Natasha. I'm your dentist for today. How can I help you?
Okay.
Why? Because you already did the examination. You already got to meet the patient. The question here is about management. So you've already seen that patient. You got to know them. Now you're just going to continue with it. If it was here, the first question, which is ask question, gather information. Hi there, Safe. My name is Dr. Natasha, and I'm the dentist here for today. How can I help you? I'm going to start telling you I have pain. Oh, I'm so sorry you're having pain. And we go from there. However, if I go with provide diagnosis and treatment options, so thank you for your patience so far, Safe. We got the diagnosis, we got the results and the findings from the examination, and I'm here to discuss with you what happened and why it happened. So what happened is you go on from there, and we're going to go with Natasha. Go ahead. How are we going to break it down?
So I have some findings to tell you about the pain you were feeling on the tooth.
Okay.
It seems that it is reversible pulpitis. Do you know what that means?
Sounds like a really fancy name. I don't know.
Yes.
Is that bad or good?
Yes, it is a good thing actually.
Oh, it's a good thing?
First, pulpitis means that you have some inflammation on your soft tissue in the tooth. So
okay.
to be exactly precise, if I start from the beginning, the tooth has 3 parts. It has the top part, enamel, and then dentin, and then inside of the tooth is our blood vessels and the nerve. So when the outside tissue, enamel, and dentin are hurt. And
you mean the worms are eating my tooth?
Yes, exactly. All the bacteria and came to the now they came to the soft tissue inside, and they're making inflammation to that tissue. They're bothering it, and it makes the inflammation now.
But doctor, is that bacteria, is it dangerous?
It is, if it goes all the way to the tissue, and then but in your case, it's a little bit different. We still have time. We catch it just right on time, and we just a moment. So in your case, we are lucky that we catch it. It is just the start of the process, so we still have time to clean up everything and cover that.
I'm a lot relieved now.
Sorry?
I'm a lot relieved now.
Yes, you should be, because we still have time to clean up everything and try to save the pulp tissue inside of your tooth. And so I'm sorry, but I'm a little bit concentrated because my kids are around me, and so I cannot talk straight. That's why in the beginning I didn't want to go on camera and everything. But okay,
that's fine. You can always refer to your next candidate.
Yeah. So as I said, we still have time to save your tissue. So that's one of the options that what we can do. So we can clean up the decay on your tooth to the some point, and then cover the pulp and the rest of the tissue, and put some temporary filling on it, and give some time to heal. So give time to your tooth and to your organism to heal. And so that means that it will be a couple of session treatment. You will need to come couple of times back to the clinic.
Okay. So Dr. Natasha, once we finish talking about diagnosis, which is what and why, once we finish that, we need to make it an effective communication. So we need to end it there and ask the patient if they have any questions regarding that before we proceed to what we're going to do. Once the patient is interested in what we're going to be doing, we give them the treatment options.
Okay.
So now I'm not sure if you finished telling me what and why, but we're going what and why and what's going to happen after, and temporary removal and waiting and all of that. But let's talk about what and why, and we finish it and be like, thank you for your patience so far. However, do you have any questions for me before we proceed to the treatment options? And if the patient says, but what are those like germs you're talking about, the microbes, like you're going to remove them? Are they dangerous? These are the questions the patient is going to ask. Or he must be like, you know what? I'm good. What are my treatment options? Now I'm willing to treat it. Okay, so your treatment options are 1, 2, 3. So I have to go in a structured approach. We finish what and why, and then we give treatment options. So the question is here, provide diagnosis, what and why, and treatment options. So now you finish the what and why. Now I'm going to go to Dr. Rami. And Dr. Rami, can you please proceed with the other part of the question?
Okay, so at this point, like I just introduced myself because I just entered the room.
That was in the
or I
previous
was-
case.
Oh, okay, so now I'm just like starting right away.
You're starting right away, but you're
with the
taking the
treatment.
patient from somebody else. This is not going to happen in the exam, but it's going to happen as a natural
Okay.
introduce to the patient. Like you've met, you just start to talk to the patient. You're like, thank you for your patience so far. So I'm going to give you the treatment options.
Yeah, so as Dr. Natasha explained to you, you have reversible pulpitis, and for this disease, or how do you say it?
For this condition, for this disease, for
Yeah,
this filling.
for this condition, what we usually do is just a simple filling,
Okay.
and your tooth can be saved,
Oh,
like
okay.
usually. And
Is that the only
so-
option, doctor?
yeah, that's for because we want to, our goal is to save your tooth. So what we're gonna do is we're just gonna remove the cavity, the caries,
Okay.
and then after that we're gonna fill it and we're gonna see how it goes.
Oh, sorry.
If I can say, we can always give an option of no treatment, which will proceed in further infection of your pulpitis and come to the necrosis.
So what are my options, doctor? I'm not quite sure if
So
I
we
got
can
my
do no
options.
treatment or treatment. And just
Okay. So no treatment is an option. No treatment is an option. However, we do not recommend it as a professional dentist. Okay, but like how much time? Like right now, I'm not really in the mood of being at the dentist, and I'm not really in the best financial state. So I'm not ready literally to treat this tooth. If you can just prescribe me some Tylenols, and then I'll just think about it and come next month probably if I have the money.
Yeah, we can do that, but the problem is that it can progress, and then the tooth, the cavity can extend into the nerve, and then the complication will be more, and you'd have to do root canal treatment and extract the tooth, and the pain will be even stronger.
Okay.
So that's why we recommend to treat you immediately rather than.
But doctor, you're making it sound very scary actually, with all those like infections going to go deeper in my bone. Is it actually that dangerous?
I mean, yeah, it might not happen like right away, but with time, eventually it's going to reach the nerve and you're going to need root canal treatment.
We always need to acknowledge. So even if I face you with a sentence like, you're making sound very dangerous, like, is it actually that dangerous? Is it that risky? You have to acknowledge. You have to acknowledge that I'm scared. You have to acknowledge that I'm anxious about it. So I understand you're scared about it. However, it is not dangerous right now. I understand you. I understand that you're feared. I understand that you're scared about this. However, it's not that serious now if we take care of it today. And that's why I'm pushing towards doing it today than doing it later, because we don't want that bacteria and infection to proceed further into a bigger issue. So I'm not here to scare you. However, I'm here to help you. So you have to show that you acknowledge all emotions, and then you have to show that you can provide a professional diagnosis and treatment without delaying the process for them. So, but doctor, like, I don't have the money for it for now. I might not be really into it now. I might do it next month. Like, I usually just go for my daughter cleaning. I don't go for myself. Honestly, it's everything for them. Like, it's not for myself. So I'm not looking to fixing my tooth now. I'm just trying to get out of pain. So can you please just prescribe me some, even like Tylenol doesn't work sometimes. If you can get me like, I don't know, like a high dose of Advil, that's going to work for me for a month. And then after that, we can proceed with the filling that you're talking about. How does that sound to you, doctor? That would work for us, both of us. Come on.
I mean, I can do that, but I wouldn't recommend that.
Let's do that then.
But the like I mentioned earlier, the problem is if you delay it, then you might have to pay even more
I'm not gonna
money.
delay it. Yeah, I'll just come next month. But I'm here just today for my daughter. For me, I'll do it next month. Just let me get some type of painkiller, like a strong one, that will get me until next month, and I'll get back to you. And I promise I'll do it.
I mean, I can't guarantee that in a month your tooth will be in the same condition. It might deteriorate. So my recommendation is that you treat the tooth immediately. And if you have financial problems, we can arrange and we can discuss that also, and we can find a solution for your financial issues.
Yeah, but what are you gonna do it for free? Because I really don't have money.
I mean, do I say like I can't do it for free, or do I just like ignore what he said and then
You
say that-
acknowledge and then you face
okay.
it. So I understand you're having financial situation where it's tough for you. I know it's tough for most of us now after what's been happening out there. However, we can do our best to help you as a professional dentist. See, always try to cover yourself.
Yeah.
So if I tell you you're bad, you are Dr. Ram, you are bad, you're gonna acknowledge that. Be like, I understand your frustration. Have you had a bad experience with another dentist that makes you think that I'm bad? However, people might think dentists are bad, but they're trustworthy. So try to always acknowledge emotions at all cost.
Yeah.
So if I tell you bad things, you acknowledge it and then you face it with something else. You're going to do it for free. I don't have the money. So you figure it out, to be honest. You guys, aren't you saying you're an advocate for patients and for oral health and general well-being? Well, there you go. I can afford for a filling now and you guys are making, that's how you can afford for your Lamborghinis, guys. Like you guys making a lot of money. You can't do this one for free.
I mean, so we don't do free treatment in our clinic, but I can refer you to some programs, governmental programs, if your financial situation is that
Perfect
problematic.
answer. Perfect answer. How
Thanks.
about what's gonna happen for today? Are you gonna let me go pain like with pain?
No, my
Then you're
job
gonna
is
prescribe
to.
me the Advil then.
Yeah, we'll prescribe the Advil, no problem.
Thank you very much, doctor.
Is there anything else I missed?
Beside you, what do you think? You did a mistake, but we'll leave that mistake. We'll talk about it later. Is there anything you missed? You tell me from all the information that I gave in to you and Dr. Natasha. Is there any information that you guys missed? I know in the chat, some people are saying they're talking about the alcohol. Although Dr. Amal is saying, so let's read what Dr. Amal is saying and we see if that's too extreme or not. So she's saying alcohol causes dry mouth because it's diuretic. Halitosis carries an infection. It is so acidic that may cause tooth wear. It is one of the contributing factors for squamous cell carcinoma. Spontaneous gingival bleeding, cellulitis. Moreover, it advises you to cut off alcohol. It's also affecting your mentality and your general health, especially the liver. Do we think this is too extreme or this is benign for the case? Or part of it is what she should be saying?
I mean, the patient said occasional drinking, so I don't think it's that serious.
Yes, but again, as I said in the first second of this lecture, we cannot ignore any word comes out of the patient's mouth. And this is a word that came out of their mouth. They said we drink occasionally, and they are 17. So you're not going to be their parents. You're not going to report them to public health, but you're going to let them know and educate them. Because your part as a dentist is to, as a patient-centered care, is to advocate for patients. Your part in your clinic is to advocate, 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 advocate at all cost. So what is you doing? What are you doing to advocate for this patient? I will consult. I will tell you that you cannot, just something I wanted to bring it to your attention. I know you're 17 years old and not yet eligible or legal for you to have alcoholic drinks yet. However, there are too many things in the alcohol that can affect your oral health and general well-being. So from Dr. Emel said, I'm just going to mention that it can cause dry mouth and it's going to cause later a decreased incidence of caries and increased incidence of infection that can happen. It can also affect your systemic and general well-being. And it can create some dependency. And I will stop there. So I'd advocate for you because I care for you. I always say I care for you because I care for you because I'm a professional dentist. I would advise you to stop drinking at this age and to look into the benefits and the risks of drinking alcohol. However, we said we have a printout. I will give you a printout that has all the benefits and the risks of having alcohol, so you can review it and ask me any further questions if you have it. How does that sound to you? Sounds good. Thank you very much. You've done your part. This is you addressing the word that uttered by the patient. Now, other parts that Dr. Amal was saying, squamous cell carcinoma, contributing factors, celladinitis, moreover, this is not really necessary in the exam. It's more like it's going to kill your time in the exam more than it's going to give benefit. Is what she's saying wrong? No, it's not wrong. But in the exam, in our next lectures, we're going to look at what the criteria in the exam, with the passing criteria in the exam. Too many things in the criteria are going to have the mark 0 next to it. And it's going to be marked as a competent. And we know in the exam, you've got competent, minimally competent, and not competent. So in order to pass the exam, from the 3 categories, competent, minimally competent, not competent, you have to match the minimally competent in order to pass. The minimally competent is the points that you cannot miss, like SOCRATES. They're going to have the points next to them, like it's going to give you 0.2 mark. The competent section is going to have points, but all of them are going to be zeroed. So it's not going to affect you passing or failing. In order to pass the exam, you need to accumulate a mark of 1. And that mark of 1 is going to have 5 items of 0.2. So 0.2, 0.2, 0.2, 0.2, 0.2. You get the 1, you pass the station. The 0.2's 5 points are in the minimally competent. The competent are going to have 3 or 4 marks, but those marks are marked at 0. So even if you get them, it's not going to let you pass. So if you be the perfect dentist, you're not passing. If you be the minimally competent dentist, you pass. And even in the minimally competent, you have to gather 1. So you have 5 of those, 0.2, 0.2, 0.2, 0.2, 0.2, you pass. What if you get 4 0.2s? You fail the station. What is an 0.2 here, for example, in this case? This patient talking about alcohol, and you guys ignored it, for example. That's a red flag. So what's a red flag in situational judgment exam is the one of the 0.2s, because you cover most of them, but you don't cover 1. So that's why we focus on a structured approach, the BST method, where you cannot miss anything on the checklist. So what Dr. Ahmed is saying is not wrong, but it's from the zeros, not from the 0.2s, from the competent one, but they're looking for the minimally competent. The starting dentist should at least tell their patients that alcohol causes dry mouth. However, we can take it further and might cause squamous cell carcinoma, and might cause infections. These type of things is not gonna cost us to pass the case. Let's look at what Dr. Sunaya is saying. We have to tell patient that oral health and general health are related, and oral health importance. We can do payment plan or help you whatever I can. Help you however I can, something I would not say, it's a 0. However, payment plan is an 0.2 because it solves an issue. Offer government-funded plan installments, this is an 0.2. If she mentions this or mentions payment plan, she's a pass. A new patient, doctor, we have to make sure that this medical history is clear before we give analgesics. Not bad questions at all. But are we going to go into asking questions or providing management? We're going to go to providing management. However, is this question that Dr. Sunaya, sorry if I'm pronouncing it correct, So Nayana, if we want to ask for questions, although it's a management case, is that allowed? Yes. These are the cases where we can go back. You know what? We're going to prescribe Advil, for example, or Tylenol, but I want to make sure your health history is all in check. Is that okay? We ask. We get consent first. Yes, that's okay. Alrighty. Is there anything regarding your medical history that I need to be aware of? No, not really. I'm fit and healthy. Any medications you're taking? Any hospitalization? Any meds you're taking? Any signs of symptoms? Are you being followed by your MD? Yes. If everything is in check, sounds good. Now we'll get back to the management. You got where we need to go back and forth? These are the things. Okay. What other answers do we have? Can we say we can remove caries and give temporary filling, and later he can do a glunic, whichever from free treatment? So are you going to remove that? This is for Dr. Rajbir. So are you going to do that and remove that filling and excavate the bacteria from the tooth for free? I can literally face you with that question. You cannot be providing anything for free. And the approach for removing caries, you don't really have to do it in multiple visits. You can do it in a single visit. You do it in multiple visits if he has like 10 reversible pulpitis. You excavate all of them, you put a TF, a temporary filling, and then the next appointment you do like a permanent filling. You control the caries and then you do the permanent filling. So reversible pulpitis, it can be done in one session. We're going to remove the filling, replace a permanent filling. With a liner, without a liner, it's not a must information. I want you guys to get the idea of the situational judgment exam. It's not a pure theory exam. It's literally how you deliver a proper message and not missing a word out of the patient's mouth. What other answer we have here? Is it okay to advise them regarding alcohol? I believe we already answered that. We cannot forget anything that the patient asks. So Nayana asked also, can you please repeat how minimal competent can pass and competent can fail? Would not get that. Dr. Rami and Dr. Natasha, did you guys get how would you pass and how would you fail a station from a competent, minimally competent, and not competent?
Yes, we will pass the station if we address the chief complaint of the patient. If we give the chance.
No, like how would you, like the way I described a competent, so the criteria for each station, and that's for all of you, if that's the station, it's going to have the criteria, it's going to have competent, minimally competent, and not competent. Yeah. The fail is not competent. But how you get the fail? You get the fail if you have the mark of 0.
How do we get the fail?
Yeah.
If we don't address something critical into the case, then if we
and where is that something critical? Is it in the competent or minimally competent?
In a minimally competent.
Correct. The minimally competent is going to have the 0.2. 0.2, you're going to have 5 of them. 0.2, 0.2, 5 0.2s is going to give you the mark of 1. You pass the station. If you have one missing 0.2, your grade overall in that station is going to be 0.8. You said 4 correct information, but you have 1 missing. It's a fail. What if you say the correct information in the competent section? So competent section is going to have the correct information. If you said them all, they're going to give you 0 for that. It's still not a pass because they want you to cover the minimally competent part. Alrighty. So now, to summarize before we close up, we have 2 types of stations. Dr. Rami, Dr. Natasha, what are they?
Role play and written.
Role play and written. And role play and written can come in what way? Can come in an asking questions.
Gathering information and gathering the information, and the other one is
patient management.
Patient management.
So you either ask or you provide. We said we have 7 steps. The first 5 are
Socrates, and then medical history, dental history, social history, examination, and diagnosis, treatment, options.
That's it. So if it was a written station, what are you going to write in that written station? You're going to literally write whatever you're going to say in a role play station. How? If it's about pain, you're going to go through Socrates. You're not going to write Socrates on the paper, that's for sure. But you're going to mention the same points. You're going to be like, I'm going to ask about medical history. I'm going to ask about hospitalization. I will ask about dental habits. I will ask about alcohol history, smoking history. So whatever applies to the role plays, it gets applied to the written stations. So both of them are nice. And to be totally honest, personally, I would prefer role plays over written stations because role plays can give you more hints of passing that situation. Because there's a patient can answer you for your questions. However, the written station, if you don't know the point, if you don't know what they're talking about in the written station, you might miss one of the fives. You might get an 0.5, an 0.8. What if you got the minimally competent 5 0.2s? So now you have the mark of 1. But you said a single mistake from the not competent. It's a -1. So you got the 1, and now it's a -1. You're back to 0. So they're very serious when it comes to minimally competent, because that's how you should start in a clinic. And I love the NDEB for that change. Previously, we used to do only ACS, only projects. You keep doing 12 projects for 2 days. Now they're giving you the opportunity to have a conversation with a patient and reduce the amount of projects. Now, skills is also hard. However, situational judgment is not as hard, and it actually prepares you for the clinic later on, which is something we all need. So don't focus on what can I memorize from Dr. Safe, or what can I gather and jot down on paper and just go and say it in the exam. Don't focus on that. What you need to literally focus on, if you're going to be part of this course or not, or planning to be in the future, is focus on being a better dentist. Understand the process. Once this patient comes to the clinic, how am I going to treat them? How am I going to start? Are they going to come and I'm just going to see them in the chair? No, he's going to come from the reception. What is the receptionist going to do? They're going to give them the questionnaire. They're going to fill it. Then the assistant is going to take them to the operatory along with their questionnaire. You're going to hold the questionnaire, you're going to read it, and you're going to revise it with the patient. And then you ask everything, and then you do the examination. Now, you are not even licensed yet, but you have an idea of what happens inside the clinic. And that's what the NDEB wants to have out of this exam. Now, they want you to see that once you're going to get to the operatory, you're not going to jump into doing a filling for reversible pulpitis, which is a very simple case. They want to see how safe you are. If you proceeded with the examination before knowing medical, dental, and social history and Socrates, you are not a safe dentist. You're just there to build them. Fill and drill and, sorry, drill and fill and bill. That's a sequence, and they don't want that. They want you to be a safe patient. Why? They want to see that you're advocating. They love the word advocate. They want to see you advocating for that patient. If they're drinking and they're underage, you have to consult them. If he's smoking, you have to bring them the good thing and the bad thing that can happen to them if they're smoking. They're satisfying their needs, but they're ruining their general health and oral health. If you keep smoking, you will have a masked inflammation and infection that you do not see in your eyes. However, there's still an infection happening in your gums, and it's going to affect your heart and your lungs. If you quit smoking, however, you will have a better oral health and a better general health, and I care for you to have that. How does that sound to you? Are you looking into stopping smoking? Do you want me to guide you through it? So you see, you have to speak in that, like, I don't want to say fluent English. It's not about the English at all, and I advocate everybody, and I love the word advocate. I advocate everybody to jump into talking, because that's the only way it will get you leveled up to go and speak to the patient inside the room. Because imagine, Rami and Natasha, for now, because you are you're the one who participated for today. Imagine you're going to that room to face that patient, and adding the anxiety factor to that station. You can easily miss on a point or two. So the idea here is to cover the 0.2s, not focusing on the competent, focusing on the minimally competent, and avoiding the not competent red flags. And that's what we're going to go through. Now, can you find this in dental books? Yes, but is it applicable to the situational judgment? No. And that's why ACJ is good as information, but we need a specific way to apply it when it comes to situational judgment. Alrighty, before we wrap up, guys, write your questions, and if you have any questions, you can ask me now. I'm just going to take a look at note from Dr. Amal. So she's saying, so we need to tell patient about the side effects of smoking, stained teeth, halitosis, nicotinic melatosis, and stain the gingiva, especially the anterior area. Nicotinic stomatitis, bone loss around the teeth, double that normal person, has a great association with squamous cell carcinoma, especially if it is with alcohol. Moreover, hairy tongue and dry mouth and reduced healing of the infection. Is that a nice answer? It is. But if I would look at this answer, if I would ask you, Rami or Natasha, whoever has the answer, from the 5 competencies from the ACFD, which competency is Dr. Ahmed is talking about? So she's speaking about smoking, nicotinic melanosis, stain to the gingiva, nicotinic stomatitis, squamous cell carcinoma, hairy tongue. Which part of competencies is these comments? Are these comments from?
When you talk about
health promotion?
Literally. But what if the case was patient-centered care? Would I still say all of that? No. What if I said none of this? Also no. So you need to know the limit. If it was a patient-centered care and a reversible pulpitis, however, he's smoking, then I will say a thing or two from smoking. And we're going to know when to say it in our next lectures, because there's specific areas where you're going to talk about it. Because, for example, is you have reversible pulpitis, the patient is smoking, and the question is manage the patient. So you're going to ask questions, but you're not going to stop. For example, if I tell you now I'm smoking, sounds good. Thank you very much for answering. You move on. You don't stop at smoking and you start educating about smoking, because the question is about reversible pulpitis. However, you cannot skip mentioning anything about the smoking. So when do you mention it then? So if I say to Dr. Rama, for example, I'm smoking, it's like, oh, okay. How often? Occasionally. Sounds good. Thank you for your answers. You jot it down on paper. You proceed with the examination, and then you proceed with what and why diagnosis. You get to the management, and within the management, after you get to the complications that can happen during and after treatment, you'll be like, I will give you a printout, which is going to have information regarding the smoking habit that you're having. So I just want to bring it to your attention that it has this risks on your health if you continue with smoking. However, if you stop, you will have the benefits of a better health, oral and general. I will give you all those points in a printout, and please have a look at it and ask me questions if you have anything, and I'm here to help you. That's when we mention it. So we're not going to stop at anything that the patient says on the questionnaire. However, we're going to ask the questionnaire, gather the information, write it down, and then we start. And if the patients start to push us toward answering one of those questions, because they're smart patients at the same time, then we cannot satisfy what they want. Be like, sounds good. I just don't want you to miss anything important that to you. So I will just proceed with the treatment for now and the treatment options. And I will gonna tell you about this later on. Is that okay? Because if you get yourself into a question, you have a reversible pulpitis as management, but the patient now is focusing on smoking. You cannot waste the 10 minutes doing health promotion. You're failing the station, and the patient is trying to trick you there. So you're gonna be like, sorry to interrupt you. We're gonna be talking about the smoking habit that you're having, and you're gonna have this. We're gonna talk about this just in a minute from now. Is that okay? I just don't want you to miss anything important regarding your tooth infection. So let's talk about that first. You talk about it, you give treatment options, you finish it, then you give information about the smoking cessation habits. Alrighty? Guys, if you have final questions, let me know. And before letting you go, guys, just a final thought. Whenever you go to the stations, you're going to have a paper. If it's a written, if it's a role play. Always the information that comes in the cases, have it on the top of the page. So 17 years old, a new patient, reversible pulpitis. That's what I'm going to write on the top. On the bottom of the page, last part of the page, I'm going to write what they want, the end result. They want diagnosis and treatment options. In the middle of the page, I will put whatever I want to ask. So I'm going to write SOCRATES, medical, dental, social examination. If it's management, I will put none of that. I will put only what, why, smoking cessation. Why am I doing this? So in the exam, I'm going to keep having an eye contact and talking to the patient. However, I cannot miss the 10 minutes without delivering what's at the end of the paper. So if I end up not having time and having 2 minutes or 1 minute and a half left or 50 seconds left, I'll be like, sorry to interrupt you. I look at the paper. It shows management and treatment options. So your diagnosis is 1 to 3. Your treatment options are 1 to 3. Complications during and after. I will give you a printout. Thank you very much. Do you have any question? So that's why. Anything you get asked for in the exam in the top part. Anything you want to say on the middle. Anything that they're asking you goes on the bottom. Alrighty, so that's what it is for our lecture, for our first lecture for today. Next week on Saturday, so this course is 8-session course, and it's literally going to go the same way it went today. So it's going to be half of it theory, the important theory only, not all just dental knowledge. It's the important theory. The other half of it, we're going to be the role plays, and we're going to be doing written. So all the slides you saw here are basically role play and written. I tried my best to help you guys with it. If you're going to be joining us, it's a benefit for you. It's a very, I would say, I don't want to call it a crash course. It's a 2 months every weekend. That's all you need. This is the critical part of the exam that you need, which is the communication. So if you're going to be part of this course, be ready to open up your camera and engage, just like Dr. Natasha and Dr. Rami. And I thank you very much to both of you. I hope you guys made the benefit out of it. If you need to join or have questions, please reach out to Dr. Hafez or reach out to the email address that we provided earlier. And for the ones who are going to be joining, I believe there's going to be a discount for the first 10 to 20 people. Not sure what the number is. More administration happens on Dr. Hafez end. But guys, if you need anything, I'm here to help you. Exam is not hard. It's just a smart way of doing the exam. And if you need something, just let us know. If you want to feel more comfortable talking one-on-one, then let us know. We're also doing like consultation one-on-one for people who wants to know more of what's happening to the course. But exam is fast-paced, so people are going every week. And I wish you the best for all of you. We're doing the course on a very minimal people because it's an interactive course. So we're not taking a huge number. So we're taking, I believe, 20 only at once, and it's running every 2 months. Now, how I see it is if your exam is, let's say, in 8 months, do not jump into the last 6 months in order to get the practice and to get the course. I would rather get it sooner and you practice on the rest until you get to the exam. This exam, especially, not like, well, I mean, it's even like the AFK and ACJ. You would not recommend taking it later and going to the exam. You'd rather take it sooner, you revise more after, and you get to the course, you get to the exam itself. So it's out there for you. If you guys have any questions, reach out to Dr. Hafiz. If you have any questions for me, you can also reach out and book a consultation with me. We can talk about it further. We can tailor things toward your exam as well and know what's the best for you guys. Fees and all of that, I'm not really sure. I believe it's posted online, and there's a discount of 30% for the first 10, I believe. That's what the link was saying. But please check it out online, check it on the website, and speak to Dr. Hafez or book a consultation with me. We can speak about it further. Up until the day we meet again, which is probably next week, wish you guys all the best, and we're going to be talking as well later. Hope you guys enjoyed it. Take care.
Thank you. Thank you, Dr. Saif.
No problem. Take care, guys. Bye.